Hello, everyone. Welcome back to another session for our NCLEX review. We are on day 53 out of the 90 days of review sessions. Welcome to our daily review scheduled at 9 p.m. Eastern Standard Time. And for those who are newcomers or new to the channel, welcome. And we are also encouraging you to enroll to our NCLEX program. Kindly visit our website at www.stancoast.com. Now, we have updated our library of on-demand videos and also the animated videos. We have 3,000 NCLEX questions and also the 200 NGN test questions. And we also have the audiobooks and also the flip book as part of your subscription that you can use for the entire 6 months. Now, this is all self-paced and you can access this 24/7. Now, please don't forget to like and subscribe. And if you find this video helpful to your learning, hit that like button so we will know that you are really participating in our sessions. And also, I want you to encourage your friends who are also preparing for the NCLEX to join with us. This is completely free. Now, let's move forward to our discussion today, and we'll be focusing on the Alzheimer's disease, which is basically our main topic today. We'll be dealing with the test questions and also the theoretical foundation as well regarding to the Alzheimer's disease. So here we go. We have our first test item, question number 1. A 70-year-old individual is brought to the clinic by their spouse who mentions the patient is struggling with solving everyday problems at home. To evaluate the patient's current cognitive state, what should the nurse ask? Is it A, do you feel sad right now? Or is it B, how do you view yourself? Or C, what did you have for lunch today? Or D, where were you from, or where were you born? So this is a preliminary type of question that you can ask to the family member, especially if they're worried about maybe their spouse having issues, maybe possibility that they are developing the Alzheimer's disease. So please read the question. It stated, a 70-year-old individual is brought to the clinic by their spouse who mentioned the patient is struggling with solving everyday problems at home. To evaluate the patient's current cognitive state, what should the nurse ask? Is it A, do you feel sad right now? B, how do you view yourself? C, what did you have for lunch today? And D, where were you born? For those who are new to the class, welcome. Hello, everyone. Okay, well, I'm going to get started here with answering the distractors, okay? Let's start with letter D this time. What do you think about the letter D option? Where were you born? So this test question basically is going to ask more of, let's say, it's like a long-term kind of memory testing. So which is going to be relatively preserved in the early stages of dementia. So especially for those patients with early Alzheimer's disease, typically have more, they have difficulty with recent memories than with memories from long ago. And so this will not be an appropriate question to ask to the patient because, again, this is going to test long-term memory, which is going to be preserved more in the early stages of dementia. So we are going to eliminate letter D. Again, this is a test question about dealing with long-term memory. We are eliminating this one. Long-term memory preserved in early stages of Alzheimer's disease. Now let's have letter A. Do you feel sad right now? Do you think that this is going to evaluate the patient's current cognitive state? I believe no. The letter A actually is assessing the patient's emotional state. It's not asking about the cognitive function. So it's basically asking about their current mood rather than cognitive abilities. So we are tagging this as an incorrect answer as well. This is more of asking their emotional state. We are asked about current cognitive state. Now let's have letter B. How do you view yourself? This is also incorrect because this question is geared towards the self-perception, how they think about themselves, and also their emotional health, but it's not targeting the cognitive abilities of the patient at the present time. Okay, so this is about self-perception, not about cognitive ability. All right, and also emotional health. So we have letter C as our last option. What did you have for lunch today? So this question is asking the patient about recent events, such as what the patient had for lunch. And this is going to target assessing the short-term memory. Assesses short-term memory. Okay. Now, if there is going to be an impairment in the short-term memory, this is a sign that there is now cognitive decline, especially if there is going to be a dementia or an early onset of the Alzheimer's disease. This is the first sign, okay? Early sign of cognitive decline is the amnesia, especially for the recent events, recent memory. So we have our answer as letter A, or letter C rather. All right, please don't forget that about checking our patient, especially during the early phases. This test question is geared towards assessing the patient's cognitive state, and this question is focused onto detecting if there is onset of the Alzheimer's, okay? And the question specifically about asking the patient about their lunch, this is to target short-term memory, all right, which is commonly affected in the early stage of Alzheimer's disease. All righty, guys, let's move forward to the next question. Number 2, the nurse is discussing the evaluation process for Alzheimer's disease with the patient's adult children. What should the nurse explain? Is it A, family history is the most critical risk factor for Alzheimer's? Is it B, Alzheimer's is diagnosed by excluding other causes of dementia? C, new medications can significantly reverse Alzheimer's symptoms in some cases. And D, brain atrophy seen on MRI can definitely diagnose Alzheimer's. So here is a question about the evaluation of the Alzheimer's disease with the patient's children, adult children. Evaluation of the Alzheimer's disease. So what do you think would be the best explanation about, or what you should explain to the patient's children regarding the evaluation of the Alzheimer's disease? Is it the family history? Is it Alzheimer's diagnosed by excluding other causes of dementia? Or is it C, new medications can significantly reverse Alzheimer's symptoms in some cases? Or is it D, brain atrophy seen on MRI can definitely diagnose Alzheimer's? What do you think? All right. I'm seeing letter A's. That's wonderful. Okay, let's start to eliminate our other options. Letter D. Let's talk about the brain atrophy seen on MRI. Is this correct? Letter D. Brain atrophy seen on MRI can definitely diagnose Alzheimer's disease. Well, there is going to be brain atrophy, particularly in some areas of the brain, and this is associated with Alzheimer's disease, but it is not specific enough to provide definitive diagnosis on its own, okay? And as we know that brain atrophy can also be seen in other patients or any, I'm talking about the other conditions, so it will be an insufficient diagnostic criterion for the Alzheimer's disease, okay? Insufficient diagnostic test for AD, Alzheimer's disease, because again, the atrophy can also be seen in other conditions. Brain atrophy is also seen in other conditions. All right. Again, it's not going to be specific. So we are eliminating letter D. Let's have letter C. New medications can significantly reverse Alzheimer's symptoms in some cases. Do you think that is a true explanation there? New medications can significantly reverse Alzheimer's symptoms. Do you think about that as a correct answer or an explanation? Well, there is no drug that is known yet that can help slow or that can reverse, rather. No drug has been known to reverse the Alzheimer's disease symptoms or manifestations, but what we have currently can slow down the progression of the symptoms. No reversal, okay? No reversal. This is false. Okay, this is incorrect. Meds for AD can only slow down the progression of symptoms. Slow down the progression of symptoms. There is no drug that is known yet to reverse the manifestation. It is a chronic condition, yes, and it is a gradual. It can be progressive as well. Let's talk about letter A. A family history is the most critical risk factor for Alzheimer's. Family history, it said. Yeah? Do you think family history is the most critical risk factor? Well, we know that family history is a risk factor for Alzheimer's disease, but the family history is not the only thing that is a risk factor. There's also age, which is the actual most significant risk factor, okay? So, family history is the most? No. The word the most is making this statement false. Incorrect. Family history is not the most critical risk factor. However, age is, or advancing age is the most critical, significant risk factor. No, not family history. And so as we know that the advancing age can increase the likelihood of the development of AD more than the family history. So we are marking this wrong. So we have letter B as our last resort, which is Alzheimer's is diagnosed by excluding other causes of dementia. What does that mean? Well, as we know that the Alzheimer's disease is primarily diagnosed through a process of exclusion, okay, where Other potential causes of dementia may be vascular dementia, or let's say the Lewy body dementia, or other reversible causes like vitamin deficiencies are going to be ruled out first. Okay, so as we know that dementia and Alzheimer's, actually Alzheimer's is just a part of the dementia. When we are talking of dementia, there are so many other causes, and so this is a much more specific condition under the neurocognitive disorder. Okay, so this is going to be diagnosed by excluding other causes of dementia. Like we know that decreasing blood flow, or let's say vitamin deficiencies, can actually lead to dementia. All right, or it could be vascular type of dementia. So these will need to be ruled out first before a patient can be exactly diagnosed as Alzheimer's. So this is the most correct answer here. All right. Good for you guys for answering letter B, which is somewhat kind of tricky here, but we are talking about the clues, the words most. It is not true, guys. It's not family history, but the advancing age. All right, let's move forward to the discussion of our Alzheimer's disease, trying to test you about your knowledge first before we're going to proceed with our lecture. Now, again, the Alzheimer's disease is a progressive, it is a neurodegenerative disorder, it is a chronic disorder, and there is going to be a cognitive decline and also memory loss that can worsen over time. This is progressive, and it can affect the patient's cognition, memory, and behavior. Now, guys, this is a condition that is most common form of dementia. It's about 60 to 80% of all cases in dementia. Take note of that. It is the most common form of dementia, and it will affect primarily with the older adults, but it can start with mild memory loss and it can progress to severe impairment, and it will eventually interfere with the patient's daily life. Now let's identify here, guys, the different risk factors of the Alzheimer's disease. So what are these? Well, primarily the advancing age. That is the topmost risk factor. It is the greatest risk factor, and especially the risk will be doubled every 5 years after the age of 5. Risk is doubled every 5 years after age 65. Okay? So take note about the advancing age. Now this time we'll talk about the genetics. Family history is also going to be a factor, but it is secondary. Especially if the person has a first-degree relative that had a diagnosis of the Alzheimer's disease. And this is caused by what we have as the APOE gene, which is the apolipoprotein E gene. Okay? Now, there is going to be a mutation here, which is specific, the APOE4 type of gene. This is the mutation that's actually predisposing the patient to develop the AD, or Alzheimer's disease. And this is the strongest genetic factor that is going to be identified for the late onset Alzheimer's disease. And again, it can occur typically after the age of 65. Now, for those individuals who are inheriting one copy of the APOE gene, E4, or let's say the heterozygous type of gene, they are at higher risk of developing the AD. But those who are going to inherit two copies, both parents, or homozygous, they have much higher risk to developing the Alzheimer's disease. Now, we're going to talk about the tendency here. There is a higher tendency for this patient to develop at an early age, especially if they have this mutation. Okay, again, APOE mutation is going to put the patient at higher risk to develop at an earlier age. Now, this is going to cause the presence, or let's say the accumulation, of those beta amyloid plaques that is going to occur in the brain. And this is the hallmark pathology that is very identified, that it is distinct to the Alzheimer's disease. This is what we have: beta amyloid plaques inside the brain. Now, with this APOE mutation, the patient is going to have a much increased risk of more of the degeneration of the neurons, and they will have impairment of repair of the neurons as well. And the person here is going to, with the incidence of APOE, this is going to affect the general population as well. All right. Now, other risk factors is the Down syndrome, wherein they will have much higher risk due to the presence of the extra chromosome. Higher risk because of the extra chromosome. There are some other factors that can also lead to the Alzheimer's disease. It will be the cardiovascular factors such as the hypertension, high cholesterol, diabetes mellitus. So if the patient has poor control of these conditions, then they are a higher risk to developing the Alzheimer's disease as well. Now let's talk this time on the disease process, the pathophysiology. And it can really affect the brain in so many ways. So first thing here is the amyloid plaque, which is caused by the accumulation of the beta amyloid protein fragments. So what are these things? They're actually the clumps of the beta amyloid protein fragments that are building outside the neurons. And normally, guys, the beta amyloid is broken down. Supposedly, the beta amyloid proteins are supposedly broken down, and this is going to be eliminated in the normal person, right? But in a patient with Alzheimer's disease, it will start to accumulate and will form those plaques. Now, what happens when these plaques start to form? This can now interfere the communication between the neurons, and this can now contribute to the brain cell damage. Again, the plaque formation can impair communication between the neurons. Okay. Now, there's also another problem in the AD, and this is what we have as the neurofibrillary tangles. So what is this? When you're looking into the neuron itself, inside the neurons, you will see these, what we call as microtubules, and the microtubules are intended to help maintain the cell structure and also transport the nutrients. Okay, supposedly the microtubules will help maintain the neuron cell structure. However, when there is a problem here in the AD, take a look here. These are the microtubules in the neuron. Look at the regular formation of the microtubules in a regular normal person. However, when you have a patient with the Alzheimer's disease, take note of the neurofibrillary tangles. So this is classic in the AD. There will be entanglement of those neurofibrillary structures. I mean the microtubules rather. There will be entanglement of those microtubules because the tau proteins, we call them as the tau proteins. Hang on a sec. Why I can't write here. Let me shift this screen into a smaller one. The tau proteins are supposed to stabilize these microtubules in the normal person. But when the Alzheimer's disease is going to happen? Those proteins will become abnormal and they will form those twisted fibers. And this is now what we call as the neurofibrillary tangles. So again, the tau proteins are supposed to regulate, they are supposed to stabilize the microtubules. But in the AD, they are now going to be abnormal. This will lead to the twisting of those fiber. So with this entanglement, the neurons will have disruption in their transport system. They will not be able to communicate well from one neuron to the next. And eventually the neuron will die, okay, after there is neuronal dysfunction. So after there is that neurofibrillary entanglement, the patient will have the accumulation of the amyloid plaques. The person will end up with this neuronal loss. They are going to die, especially in the areas of the brain that is crucial for the memory, also for those neurons that are responsible for learning and also the cognitive function. And with the progression here, this will definitely cause the gradual decline in the patient's cognitive abilities that you will see in this patient with the Alzheimer's disease. So again, don't forget, guys, about the disease process. We have the amyloid plaques formation, the entanglement occurring because of the dysregulation of the tau proteins. The microtubules are now entangled, right? And then with a progressive AD, it will lead to neuronal loss because of the dysfunction in the neuron, wherein there is eventual cell death. Now let's talk here about the assessment findings in our patient with AD. What do you think are those manifestations? Well, let's talk first about the mild symptoms. And this is going to start as confusion, maybe mild amnesia, memory loss. They will start to be disoriented. They will get lost in similar or familiar surroundings, rather. So this is what we call as the agnosia, which is basically being unfamiliar with their surroundings. They are not going to remember exactly those familiar surroundings that they known before. Even those objects that they were familiar in the past, they're no longer going to identify that as a common object. Okay, so this is what we call as agnosia. Now, what else? The patient will have trouble with doing those routine tasks. Let's say hygiene, taking a bath, shower, or let's say reminding themselves to use the bathroom. Those regular routine tasks will be kind of problematic for them. They will need more prompting, okay? Or let's say if they are taking a meal, they probably would just kind of sit there, not doing anything. Maybe we'll take a pause, and they would need to be prompted what to do next after they are feeding themselves, putting the food in their mouth. So that could be another mild symptom here. So what else? There's going to be change in their personality and also their judgment. And when the disease progresses, this is going to be much more difficult. This time, they will have much more intense problems with their feeding and also bathing. This is what we call as apraxia. Okay, so they are going to be some of these patients will have the inability to perform because of even though their motor function is still intact, they can still do it, but they just have that condition we call apraxia. Even though their motor function is still intact, they just don't know what to do next. That's basically what apraxia is. And they're going to be more anxious this time. They will be suspicious, agitated, and most of the time, if they have a caregiver at home, or let's say in the assisted living, they probably would think that their belongings have been taken by the caregiver. They would suspect that there's theft they would become so suspicious. They would call family members that maybe their belongings have been taken by the caregiver. So this is a common occurrence, guys, especially in the moderate symptoms. Now let's talk about sleep disturbances. Yeah, this is a common theme, especially for those sundowning AD patients. They will be wandering mostly in the evening time, and they probably wouldn't wander in their yard at home, even in the middle of the night or early morning. Now, let's talk about the pacing. This is just their expression of their anxiety as well. And here, the patient will have difficulty recognizing their family members, even friends. They will lose the ability to recognize them, even they were familiar with these people in the past. Now, let's talk about the severe symptoms. This is going to be the most difficult group of manifestations here, and you as a nurse would be challenged greatly here, especially if they're going to be in the long-term care or the memory care or the dementia unit, or let's say if they're going to need acute care in the hospital. They're the most difficult people to deal with, especially that they will have a reduction in their speech ability. They will not be able to talk, and also their nutrition is going to be affected greatly. They will have anorexia and also significant weight loss. There will be malnutrition. And so this patient would be quite a challenge, especially when we are treating them with other issues. Maybe if they're treated for pneumonia, or it could be urinary tract infection. They are really prone to developing toxic effects of the medications because of the protein malnutrition. All right. Now let's talk about the loss of bladder control and also the bowel control. They're not going to be able to manage that. They will have incontinence, and also they're going to be highly dependent on the caregiver to do their ADLs as well. Okay, so please take note about the different levels of severity here in our patient with dementia. And of course, it will start with the mild and then moderate, and then eventually they will manifest the severe symptoms. This time, let's talk about the diagnosis of the dementia. How is this going to be detected? Well, the dementia itself is going to be based on the clinical evaluation, wherein the clinical provider or the medical provider will really have to review the patient's medical history, and they're going to thoroughly look into the details about the onset and also the progression of the symptoms. So we are going to focus here about the memory loss, the cognitive decline, and also the changes in their behavior. And so we really need to establish that communication with the family members, or let's say the caregiver who is familiar with the patient. We need to obtain that baseline information on when exactly they noticed these manifestations, okay? Or the onset, or when they notice these cognitive decline and also the changes. So we'll make sure that you have that information. Now, another is the physical exam, which is going to help out in the thorough gathering of the overall physical health and also the neurofunction, right? And it will also identify other conditions that might contribute to the cognitive impairment of our patient with Alzheimer's disease. Now, guys, I hope that you're familiar with this one right here. The clinical evaluation will also include the cognitive testing, such as the Mini-Cog test. Are you familiar with this in your clinical rotations? The Mini-Cog test. There's also the MMSE, that's the Mini Mental State Exam, or the Montreal Cognitive Assessment, or the MoCA. So these are standardized testing that will be offered, that will be done to get baseline information about the patient's cognitive function. Now, if you're not familiar with a Mini-Cog test, then let's talk about it. All right. So the Mini-Cog testing is basically a very quick assessment, and this will detect the cognitive impairment. So let's talk about the mini cognitive testing. And this is the most used test to get baseline information for the mild Alzheimer's or mild dementia. And this is done very quickly. And also the testing here is focused on checking the patient's memory. That's the goal here. We're checking for the patient's memory, their executive function as well. So what are those items that will be done in the mini-cog test? What do you think are those items? Well, this will include the 3-item recall. What is the 3-item recall? So you will be testing the patient by asking the patient to recall those items. So you're going to give them like, okay, so I'm handing you, or these are the 3 items that we're talking about right now. So we are talking about a cup, a comb, or a purse. So this is something that you're going to present to the patient. And then you're going to ask the patient to remember and also to repeat 3 unrelated words immediately after they are presented. So again, you're going to ask them to remember those items, and then the testing will also involve repeating unrelated words immediately after they are presented. So this is involved in the 3-item recall. So you might use the words apple, table, pencil. And so you're going to ask the patient to repeat those 3 same words immediately. So that's one thing. You're going to have to tell them, can you repeat what I just said? Table or apple, table, pencil. So this is really going to test the patient's most recent memory. Okay. So if they can pass this, well, that's a good sign, right? But most often when they have the dementia, they will have trouble remembering even with just a few items. All right. Now, another testing that can be incorporated, or it's actually in the standard mini-cog test, is the clock drawing task. Clock drawing task. So what are you going to do here? You're going to ask the patient to draw a clock face, and you're going to ask them to place the numbers in the correct positions, and you're going to set the time to a specified hour, such as 10 past 11. So if they're going to be able to follow your direction, they're going to have to draw a clock, right? So 3, 9, 1, 2, 4, 5, 7, 8, 10, 11. So they're going to draw exactly, let's say, for example, if you're going to instruct them, can you please draw in the clock to tell us that it is 12:30, okay? So, of course, if the person is able to do it, they can really draw with the short hand pointed towards the 12, and the longer hand of the clock will be pointed towards the 6, okay? So this is really going to assess the patient's ability to properly position and set the time, okay? So this is the clock drawing test. Now, guys, the patient will be scored according to the points here with a 3-item recall, the clock drawing test. They will receive 0 if there is no correct words recalled. And there's going to be 1 point for 1 correct word recalled, and 2 points if they're recalling at least 2 or 3 words correctly. Now, the clock is scored separately, and this is going to be based on the criteria with a placement of the short and the longer hand. And of course, the patient will be considered to have a impaired cognitive testing if their score is about 0 to 2. Okay, there is cognitive impairment. So they will need further evaluation in order to determine the Alzheimer's disease. Again, guys, this is not going to be the last testing that they will have. Once they fail the cognitive test or the mini cognitive test, they will undergo further evaluation to determine if they really have Alzheimer's disease or maybe if they have other form of dementia. Now, if the patient is going to pass, well, that's a good thing, right? They probably would need more testing to identify what caused their manifestations. Maybe they have metabolic disturbances. Maybe they have some problems in, like electrolyte counts. Maybe issues with the liver or maybe thyroid function that may complicate things. Now, the advantages here for administering the mini cognitive test is that it is very short. It can last for only 3 to 5 minutes. It's the most practical testing that can be used in a busy clinical setting. And it's known to be very sensitive in detecting the cognitive decline of our patient, especially for those who need to be evaluated for the dementia. Now, I'm not going to elaborate with the other testing because this is quite lengthy, guys. The MMSE or the Montreal Cognitive Test, they are more extensive compared to the Minicog testing. Now let's go forward in our discussion here regarding the other testing. The CT scan will be one of the tools that will be used in detecting the Alzheimer's disease, wherein it will show some atrophy of the brain. The same thing with the MRI. But again, this will only serve as supportive evidence, okay? They're only going to help out in the diagnosis, but they're not definitive. They can identify the brain atrophy, or let's say the cortical atrophy. Identify cortical atrophy. But it will not really diagnose if the patient has Alzheimer's. As I have said earlier, that atrophy of the brain can be also attributed to other neurological condition. So basically the atrophy here is the shrinkage of the brain tissue, the outer layer of the brain. And also there is going to be enlargement of the brain's ventricles. So that's another finding in these imaging studies, enlargement of the brain ventricles. Again, these are only supportive findings. They're not going to give a definitive diagnosis in our patient. They are just support. As I've said, they are also present in other neurological condition. Now let's talk about PET scan. What is this? Well, this is a test that is going to detect the accumulation of the amyloid flakes in the brain. So this is going to be more specific. This is going to detect accumulation of the beta amyloid plaques, which is the characteristic finding in the AD. But guys, this is not routinely used for the diagnosis, but it can help differentiate the Alzheimer's disease from the other types of dementia. Okay? All right, not routinely used. Please take note of the word. Now let's talk about the different stages of the Alzheimer's disease. The stage 1, which is the mild stage, the patient will display the forgetfulness. They will manifest those subtle changes that probably are not immediately noticeable. And the patient here will have more of the forgetfulness, even with the recent events. So this is one of the clues. Recent event forgetfulness. Even, yes, they're both reliable, AJ. Recent events are going to be affected. I mean, they will have impairment in recalling those most recent happenings. Now let's talk about stage 1. Let's focus on the stage 1 right now. The stage 1 is also going to manifest their impairment in learning new material. They will be poorly performing at work as well because of the forgetfulness. They will have poor concentration. They will also display changes in the personality, also the impairment of their judgment. They probably would engage in inappropriate humor this time. Again, they will have impairment in learning new concepts, poor performance at work. They probably would be kind of like argumentative at work as well. There's going to be personality changes. Their judgment here is starting to dysfunctional. And they might also display difficulty in finding those words or let's say names. So please take note about the stage 1. Now guys, what are the functional abilities that is going to be retained in this patient? Well, they can still function. They can still independently do the daily activities as independence with ADLs. So please don't forget, in stage 1, they can still do those daily tasks, work. They can still socialize. They can still manage those personal affairs. Okay? But when the patient progresses into stage 2, the patient will have much more of moderate confusion. Okay? Now, there are more noticeable in this patient. I'm talking about the manifestations. They are going to affect the daily life of the patient more significantly. Their memory loss is going to worsen. They will be forgetting those details about themselves. Maybe they will not recall their address or let's say their phone number. So they will forget those this time. Again, this is in stage 2. Forgets own address, phone number. Okay? And they might also forget, or they might have some difficulty in recognizing those places that they were familiar before. So they will get lost. They will have what we call as difficulty in the spatial orientation. They will be lost in familiar spaces. And let me write that first. Getting lost in familiar spaces is common. And also, they will question, or they will be asking the same question all over again, repeated same question. Or I'll just put that, a repetitive question. All right. So they cannot even recognize that they are asking the same questions all over again. And the patient here will have a great need, especially with helping the daily tasks. They will struggle with the organization in their kitchen. They will not be able to effectively plan or maybe manage their finances. Or let's say if they were good in cooking in the past, they probably are good in following a recipe. Now, the patient will not be able to do that. All right? So there's going to be difficulty in planning, managing finances. And this is very difficult, guys. If they have not talked with their family or their children regarding the finances, their wealth, this is something that should be dealt with accordingly, especially if the patient has advancement of their Alzheimer's disease. Okay. Also, they will be more irritable and anxious this time. Irritable and more anxious. Now let's talk about stage 3. What is in stage 3? This is what we refer to as severe. Let me erase this one first. Severe or moderate to severe ambulatory dementia. So what are the manifestations in this patient with a moderate to severe Alzheimer's disease? Well, this is going to cause a progression, a much more progressed memory loss. They're gonna forget those familiar family members. They will not be able to identify them, even the close friends. All right? Not able to identify family members. Again, for those who are new to the class, welcome, guys. Even close friends, they will not be able to recognize them anymore. And here, the patient is going to be much suspicious. Probably they would be paranoid, thinking that somebody has stolen their purse, even though they just misplaced their items. They would be telling their family members, hey, that caregiver that comes in every day just took my wallet. And they will just create those false stories this time. They will start to hallucinate as well. Okay. There's going to be hallucinations in stage 3 and paranoid delusions. Let me erase this because this is getting confusing. Hallucinations and paranoid delusions. Again, they would think that they're a victim of theft. So you got to be careful with this patient, especially if you're going to be in close contact with them. They will think that you are stealing their items. Paranoid delusions. Now let's talk about their functional abilities here in stage 3. What do you think are those preserved abilities? Well, their ability this time is significantly impaired. They will require assistance with their personal care, dressing, bathing, using the toilet. Requires assistance with personal care. So you cannot let this patient just do their own care. They will not be able to do it. Maybe a case would be like you are the home health nurse, and all of a sudden when you're visiting this patient, when they open the door, the patient's overall look, they're somewhat just disorganized. Maybe they are not taking a bath for maybe 3 months, or let's say their home setting is very dysfunctional. There's probably clutter everywhere. Maybe there's poop in the living room. Yeah, this is a common occurrence, especially for those patients that are in this stage. And they really have much more difficulty in communicating this time. Their speech is also affected. Now let's talk about stage 4. What do you think are those events that are significant in the late or end stage Alzheimer's? Well, this is going to be display more severe manifestations. The patient will have cognitive decline, which is severe. Severe cognitive decline. And they will lose their ability to communicate coherently. Incoherence is one of the hallmarks. They will not be able to express their needs. Okay? And they are going to be more dependent, rather. They will be more dependent on their family members, the caregiver, for all aspects of care. And as far as the functional abilities here, they probably would have less ability to walk, decrease walking ability, transfers, going to the bathroom from their bedroom, or let's say swallowing ability is also decreased. They will not be able to swallow safely this time. They're going to be prone to choking, even with the food items that they have been using in their lifetime. And they are going to be much more debilitated this time. There is increased dependence on others. And talking about the bowel and bladder incontinence, yeah, this is going to be a huge thing in stage 4. Bowel and bladder incontinence. They're going to end up with those urinary tract infections. Yeah, very common, guys. Urinary tract infection is going to be recurrent in these people. Okay. And the reason for that is because of their weakened immune system, just being frail. They're not taking the adequate nutrition, their protein intake, their carbohydrate intake, fat intake is just all dysfunctional. And so again, they're going to be prone to catching all those opportunistic infection because of their weakened immune system. Now let's talk about the general nursing actions here for this patient with Alzheimer's disease. So again, let's focus on the general ones. Let's talk about assessing or reinforcing retained abilities and skills. This is very important. So you got to be careful in identifying those retained abilities. So we will need to promote those retained abilities. We need to encourage them to keep doing what they can in order to prevent deterioration. Now, what we're going to need to do here is to make sure we are conducting assessment to determine what tasks that they can perform independently, and also we can maintain their confidence and also independence. That's the goal of the assessment and reinforcing those retained abilities. Now, talking about consistent care, this is a big deal in the care of Alzheimer's. This will help reduce their confusion, also reduce their anxiety, since they have the cognitive impairment. So what we need to do here is to schedule predictable activities. Schedule predictable and consistent activities. This is what they need. Because if the activities are not regular, if they are like all over the place, this will create more confusion into our AD patient. So make sure that when you are the nurse, you need to ensure that your nurses' aides are in the same page, that they are informed, make sure that they're going to adhere to the established routines in order to provide a much more stable environment for this client. Now let's talk about the orientation to the environment. This is very important. We want to make sure that they are going to be, they need to feel secure. Sense of security is maintained, and also this will minimize the disorientation. And what we're going to do here is to do our verbal cues. We have to guide them physically. Also, we have to redirect them whenever they get lost around this time. And this is something that we should be doing as well. All right. Now, let's talk about the environment with familiar items. What do you think about this? Have you thought about making sure that the patient lives in a familiar environment? This is very important. So here, we're going to place those familiar objects. It will give them some comfort. It will give them a sense of continuity. And also, what we can do here is to place their personal belongings, maybe photographs. We can put some familiar decorations into their home setting. And so this will also reduce their anxiety, and it will also improve their overall well-being. Now, another thing is to validate their emotions. This is very important. It will be crucial when we are acknowledging and validating their emotions. It will also promote the emotional well-being and also communication. So we need to listen actively to their expressions of emotion, even though if they're nonverbal. We need to be empathetic in this patient. Now, Let's also talk about assisting the patient or the family with their coping. This is huge. So a huge support can really help them adapt to the challenges of the decline, especially their cognitive decline. So what are we going to do here, guys? We are going to implement, or let's say educate the family members about the Alzheimer's disease, the progression, and also we'll teach them about the coping strategies. And we will refer them to some support groups, maybe counseling, in order to help these family members to manage their stress. Now, let's talk about the monitoring of the patient's daily activities. This is going to be huge as well, because when you are able to track their changes, especially with how they do stuff in the daily basis, we can recognize those progression, especially if they will not be able to do this task anymore. So we need to have that documented in the medical record, make sure that we will be monitoring their daily activities, even during their mealtime, hygiene, their social interactions. Has there been any change in their form of interactions? Or are they now some kind of aloof, or are they more isolated during this time? And so we need to make sure that these are properly documented in order to properly plan the care as well, and to make sure that we can do the modifications. Now, another thing that we need to do here is to prompt them for their self-care tasks. So the patient here will need reminders, especially if they can still do it in the mild stage. We can prompt them, hey, I think it's time for you to take a bath today. It's been 2 days that you haven't done it. Or I think it's time for you to use the bathroom. Yeah, so you need to do the prompting in order that the patient will be reminded. Just do it gently, okay? You are going to do this gently. Do not be argumentative if they will start to reason out. Just be supportive, guys, in order that our patient will maintain their retained ability. Okay, now let's talk about promoting independence. This is huge, especially during the early stage, because this is no longer effective in the moderate or severe stage. There's no more independence in that stage. So how are we going to do this? Well, we are going to encourage them to do those tasks that they can safely do to maintain their dignity and also autonomy. And what we can do here is we're going to give them options or choices in order for them to decide what would be best for them to do during this care, okay? And we can also establish routines to our patients. We're going to have to get the plan of care much more predictable in order to lessen their anxiety. It will lessen their confusion. And as far as activities, this will include the meal times, the need for them to have their hygiene, the very basic stuff, the sleep and rest, and also recreation. These are things that should be planned out in our patient's care, okay? It should be consistent each day, and make sure that the patient is also have that capability that they can read those schedules, so they will have a quick reminder that they can review them as well. Now, what else would be needed in this patient with Alzheimer's disease? Well, exercise is really good. Daily walks, especially during the daytime, can maintain a much more healthy lifestyle in this patient. And this can also lessen the occurrences such as insomnia, okay? Yeah, it's a huge factor, especially for the sundowners. It will be a bad shift, especially if your patient had slept most of the daytime. Yeah, by the time when you're on the graveyard shift, you will be dealing with this patient all night long, and it's not easy to deal with them, especially in the acute care. So many things have, gosh, it's just unbelievable how even they can stay up all night if they just had a nap during the daytime or late afternoon. Now, let's talk about avoiding complex activities that strain memory. Yeah, this is huge, guys. We are going to minimize those cognitive demands in order to reduce their frustration. And we really want to make sure that they will stay engaged with their daily activities. So what are we going to offer this patient? What are those activities that would be appropriate for them? Well, if they are still in stage 1 or 2, we're going to choose those activities that would match their current cognitive abilities in order to avoid those frustration. They will get angry when they get frustrated. We don't want to offer them those problem solving skills. No, that will totally confuse our patient. Now, another thing that is huge in the care of Alzheimer's disease is to make sure that they're given enough time to complete their task. So make sure that this is provided to your patient, so this will lessen their frustration. It will also lessen their stress. So what are we going to do here, guys? Avoid rushing tasks. Avoid rushing tasks. Okay? They need to be allowed to complete their daily activities according to their own pace. But that's just not it. If the patient is probably in the shower for like 2 hours, well, that's not a good thing. You need to limit those, especially if this is harming their welfare, okay? What about allowing them to choose? You can let them choose if they're still in the earlier stage of the dementia, not if they have the severe type of dementia. They don't have the capability in decision making. They don't. All right. Now let's talk about distraction, music, coloring. This is common activity, especially in the nursing home or the dementia care unit. This is going to be helpful for them, especially that they are quite stressed. They just don't know what's really going on, right? They are somewhat kind of agitated of, hey, what's going on with me? Why can't I see any of my familiar friends if they are still in the mild form of dementia, right? Or Alzheimer's. And so this can really cause diversion in order to reduce their boredom and also their anxiety. And it will keep them relaxed as well. They will be more engaged in the care. So what are those things that will be appropriate for this patient? Well, we can have them listen to the favorite music, familiar sounds, coloring maybe, watching calming videos. Those are the things that we need to give them. Now, about mental stimulation, we have to offer this as well. This will at least maintain the present cognitive function. It maintains brain health. So what we can do here is we're going to offer them those very simple games. So what we can offer them will be those very easy puzzle games, huge puzzles, fewer pieces that they can just, hey, this is quite easy, I can do this. At least it maintains their it maintains their cognitive function that is still there. And so we can promote this, just adding those non-challenging, just make it easy for them. Fewer pieces of puzzle games. Do not make it too complicated. Now, another thing that we can offer to this patient is the use of reminiscing activities. So have them recall their past experiences, talk with them about activities. Let me write that first. Reminiscing activities. So you really need to engage yourself in talking with them about their past experiences, ask about their childhood memories, their family traditions, or those very significant life events. This will really help stimulate their memory recall. And they will get more comfortable with you as you're going to engage yourself in this conversation. And yeah, I found myself engaging into this very special conversations with most of my elderly with Alzheimer's patients back in the neuro unit. Quite challenging though, when they are sundowning later. Another general or nursing actions that we can do, especially if they're wandering. So here are the following. Maintain a safety, clutter-free environment in order to minimize those hazards. We're going to have to minimize those obstacles that could potentially cause them to fall. What else? We're going to have to ensure a safe mobility. So we need to have them use those prescribed assistive devices if they needed to use the walker or the tripod cane. They also need to wear the appropriate, well-fitting shoes in order to afford a much safer mobility. It will really help them with engaging themselves during the daytime. Now, we're also going to give them much closer and frequent supervision. And I've encountered this even in the virtual setting. I worked as a intake nurse. And so I've spoken with family members, even the community organizers or community directors of the assisted living. And I read in their notes about the patient's tendency to even escape from the facility. And so they will have to devise these electronic items in order to safeguard this patient if they have a tendency to elope or to escape. Yeah, there are some measures to prevent these from happening. We're going to make sure that there will be securement of those doors, the use of the ID bracelets, electronic monitoring, the use of the videos, camera. What else? We're going to have to limit their daytime sleeping. This is huge, guys. Why? If we're going to allow them to sleep all day, then the tendency is they're going to be much more wide awake at nighttime, and this would really impair their sleep pattern as well. So we want to make sure that we're going to engage them with those physical activities if they can, get them busy during the daytime, and so that they can get much better sleep at night. And of course, we can do that by having them do those physical activities during the daylight. Okay, we want to make sure that they are active during the daytime. And so when I was back in the neuro unit, I hated it when nurses allow their patients to sleep most of the day, especially after lunch. The sleeping should be limited during this time because this will really cause issues at nighttime. The more that they will get confused, disoriented, especially that, hey, what's going on? It's very dark outside, but how come people are still working? Yeah, they should be in bed around the nighttime. And so making sure that they have structured daytime activities. We want to make sure that their naps are limited. They can be given naps, but limited. We're not encouraging them to sleep most of the time in the daytime. Okay? No, it's going to cause more issues. So aside from that, we're going to have to deal with their communication. So we're going to have to approach them with slow pace when we are talking to them. Make sure that we are using straightforward language to make them understand easier, and also make sure that we are minimizing confusion and also frustration. Now, we're also going to have to personalize interactions for this patient by introducing ourselves and make sure that you are using the patient's name during the conversation, and it will maintain a personal connection, and it also reduce the anxiety, and it will promote familiarity here as well. Now, focus and recap. What is this? We are going to discuss one topic at a time in order to prevent overwhelming the patient, and we need to recap what has been discussed in order to reinforce their understanding, and also it will maintain some kind of like memory retention, especially this is more applicable in the mild form of Alzheimer's. Now, what else? We're going to have to address sensory aids. So if the patient wears prescription glasses, or let's say they are known to wear those hearing aids, then make sure that they have them on in order to have a much effective communication between the two of you. All right. Now let's talk about the optimization of the environment. communication, acknowledge, optimize the environment. What are we going to do here? Well, as I have said, we're going to make sure that their environment is maintained, that they are familiar with the environment. Make sure that their living condition, there's going to be enough lighting in order to allow proper visibility. This will allow the patient to see you talking to them, to see your facial expressions, nonverbal cues. And so if you're working during the nighttime, don't just talk to your patient in the dark, okay? You need to have the light turned on, especially subdued lights, so they can see your face while you're talking to them. It will reduce the confusion as well. Now, what else? We're going to have to use those familiar items. Items that they are quite familiar, maybe clocks, calendars, maybe those personal belongings. This can also give them some degree of comfort and also orientation. Now, let's talk about acknowledging emotions. This is huge. We need to acknowledge the patient's verbal aggression as well. We need to acknowledge their feelings calmly and respectfully. So we will first validate their emotion, and we need to de-escalate the situation, okay? So this is very important, guys. De-escalation. When you're going to be an RN, you're going to undergo the de-escalation techniques as part of the annual training. This is very important, especially for the patients with AD. You need to really have a much more effective approach to this patient, especially that their emotions some kind of like out of whack. So you got to do this. And also, you're going to have to redirect your patient as needed, especially if they are getting more aggressive. You're going to gently shift the conversation to a safer and much more familiar topic. So this will redirect the patient's focus, and it will also diffuse the tension. So this is another technique to de-escalation. Now, supporting reality. So what does that mean? Supporting reality is going to be involved when your patient experiences delusions. Then you still need to acknowledge their emotions. You just gently reinforce their reality without challenging their beliefs. So again, you're going to have to acknowledge their emotions, just gently reinforce the reality. Do not force them in what you have in mind, okay? Do not. You should maintain that perspective, that respect to your patient as well, in order to diminish the aggression. This is huge, guys. Escalation is huge, especially in the severe type of AD. Yeah, there's so many things that can happen really quickly. It will escalate. Now, let's talk about the independence and self-care. This is huge. I just want to finish this before we're going to proceed with the other test questions. We're going to assess their level of abilities, especially doing those daily activities, especially dressing, grooming, bathing. This is going to be an ongoing assessment, guys. Do not just do this once. So we want to make sure that we are doing this periodically, especially in the nursing homes. They will have regular monthly monitoring of their patient to see if there is a decline in the patient's function. Now, here we're going to have to encourage decision making, and this is specific to stage 1. Again, this is not going to be applicable to other stages, as we know that there is already much worsening in their cognitive function. It will not be applicable. So here, we are going to support the patient in making their choices related to their activities of daily living whenever possible. So this will also empower them to maintain a sense of autonomy and also dignity, and also their independence. Now, another thing here, guys, is labeling their clothing. Do you know about this? Labeling their clothing. It's not for the patient, but just in case they will be found wandering maybe in the streets. So at least the person might recognize, hey, you're from the nursing home. We can help you out here? Maybe we can take you around and we'll drive you to your assisted living, something like that. Okay, so make sure that the patient's address or maybe phone is also added to their clothing. This is quite unique, actually. Another is adaptive clothing. So what does that mean? We are going to select those clothing that may have elastic waistbands, Velcro closures, instead of having those clothing that will require buttoning, zippers. No, we are talking about simplified clothing here. Velcro closures, elastic waistbands, which will be easier for them to wear. Okay. The buttons, zippers, no, especially during the later stage, they will have trouble putting on these clothes. So starting with the earlier stage, second stage, make sure that they have these clothing available in order for them to be more familiar as well and how to maneuver with this type of clothing. Now, another thing is we're going to have to monitor their hydration and also the nutrition. Yeah, it is paramount. We need to make sure that we are monitoring the patient's food intake, fluid intake, in order that they can maintain hydration. As we know, if they are not taking adequate nutrition, they are prone to developing those opportunistic infection. So we need to monitor them as early as possible. Now, weekly weighing. What is the significance of the weekly weighing? We are going to track the changes in their weight, which is going to detect significant nutritional status and also hydration levels. And mealtime support. This is huge, guys. What are we going to do here with mealtime support? Well, we are going to assist with them or sit with them during the meals in order to provide assistance. Maybe they will require some prompting in order for them to proceed with the meals, right? They probably would just stay right there. Yeah, I just took a sip of water, and they would probably forget what to do next. So make sure that this is available in the care of your patient in order that they can maintain the nutrition. Now, bowel and bladder program. This is huge. We want to make sure that we are structuring their schedule in order that they will be reminded of when to go exactly to the bathroom. It will maintain their continence. It will prevent constipation. It will prevent urinary retention. And also, it will promote their dignity, especially. Okay, so that's about our nursing process. Let's talk about our question number 3. But before we go do that, I'm inviting everyone to kindly check the link in the description box in order to know more about how to enroll, and also send us a message, okay? And make sure that you check on the website as well at Stancoast and NCLEXcoaching.com. We have updated our library of the on-demand videos and also the animated videos. So make sure that you enroll now. We are encouraging you. Let's have number 3. What is the most effective nursing action to ensure a patient with mild dementia takes their daily medication? Yes, AJ, this is actually going to include those portable food options, finger foods, anything that can be easily taken in if they're so safe to do it by themselves. Finger foods can be useful. Those easily eaten food items. Do not make them work hard into chewing those steaks. Make sure that we have them sliced or maybe in appropriate portions. So make sure that these are also done for this patient. Let's have number 3. What is the most effective nursing action to ensure a patient with mild dementia take their daily medication? Is it A, setting up a family or a monthly medication rather? So they're going to be placed in an organizer. That's That's what letter A actually is trying to tell us. B, having a family member administer the medication. C, posting reminders around the house. D, calling weekly to remind the patient about the medication. Again, the question is asking about what is the most effective nursing action to ensure a patient with mild dementia takes their daily medication. What do you think would be best? Looking into the options. Okay. Remember, guys, that they will have forgetfulness already, even in the mild stage. They will have forgetfulness. So what do you think would be the safest option here or alternative to make sure that they are taking their daily medication? What do you think would be safest here? Yeah, you can do either, but again, we are looking for the most effective. Look for that item, guys. Okay, so let's have letter D first thing. Calling weekly to remind the patient about the medication. Weekly. Well, this is going to be insufficient for the daily medication adherence. We are talking about daily medication. Weekly, it is going to be insufficient. Weekly reminders will not help this patient, especially if they need to take the drugs in a daily manner. They would not be compliant anymore. They would be forgetting a whole lot of their medications. And so our treatment here will become less effective, especially with the pharmacologic agents. We are eliminating letter D. What about letter C? We can do letter C. Posting reminders around the house. Yeah, it seems like it's going to be a good intervention. Reminders posted in the house may not be effective, especially that our patient has the forgetfulness. Yeah, they can read, but again, recent event forgetfulness, probably they will just end up forgetting again after they read the reminder. So this is not the safest alternative here. Again, posting reminders is not an effective means in addressing their forgetfulness, as we know that they have recent memory loss. They will still overlook to forget their medications despite the visual prompts. So this is not going to be effective, guys. All right. Recent memory loss. Despite the many reminders, they will still have that forgetfulness. Oops, I forgot again. I just read that reminder in the living room. Yeah, so that is a huge challenge. So if we're gonna do letter A, setting up a monthly medication organizer, yeah, that's a good idea, but will the patient be taking their medication just looking into the organizer? No. They will just see the pill box with all the medications arranged for them to take, but will they ever take that one? If they are forgetful, no. Our best answer here is having a family member administer the medication. This would be the safest option available in our scenario. Again, based on the scenario. Don't overthink. All right? So, whenever we have a family member available or maybe a caregiver, this will really ensure that the medication is going to be administered regularly, despite the patient's ability to remember is affected. So make sure that we have somebody with them to remind them and to make sure that they are taking the medication. They are supervising them as well. Okay? Not just reminder, but actually helping them in the administration of the drug. This is huge. Correct answer is letter B. Now let's talk about number 4. A patient with severe Alzheimer's disease is admitted for surgery. What should the nurse include in the care plan? Is it A, encourage the patient to talk about the past experiences? Or B, maintain a consistent daily routine for care? Or C, reorient the patient to the date and time every few hours? Severe Alzheimer's. Maybe the interventions that you seem to understand will work in the other stages, yeah, but maybe those interventions are no longer applicable this time when they have severe Alzheimer's. Again, guys, this is a patient with severe Alzheimer's. So whatever those interventions that you deem effective when they are still in stage 1 and 2 probably will not be effective this time when they have the severe type of Alzheimer's disease. So what would be the best option, especially if your patient is going for the surgery? So what would be included in the care plan? Let's have letter D. Provide current newspapers and magazines. Do you think that this will work for them? We are talking about severe dementia. Provide current magazines and newspapers. Well, when we are talking about a severe case of Alzheimer's disease, they will not benefit from reading current materials due to the cognitive limitation. Not effective. Because of the severe cognitive decline, they will not even bother reading into the material. They will not really understand what's in the newspaper, what's in the magazine. So they will not have the ability to understand and also engage in new information. Their comprehension is greatly diminished. Decreased comprehension. So despite the newness of the magazine or newspaper, they will not understand what they're going to be seeing in that. They will have no clue at all because of the cognitive decline. Their brain's not going to interpret those new information. What about letter A? Encourage the patient to talk about past experiences. But guys, don't forget, we are dealing this patient that has what? Planned surgery. So if you're going to allow them or encourage them to talk about the past experiences, do you think that this will be helpful, especially that we are preparing the patient for the surgery? Well, with the severe type of Alzheimer's disease, they will have a significant memory impairment. And so even with the past experiences, this is going to be very difficult, guys. We're talking here about severe Alzheimer's disease. Even the past experiences that is known to be like for the other forms, let's say mild or second stage, the patient can still recall those past experiences, remote experiences. But here in the severe stage, this is more challenging to recall those old experiences. Even childhood experiences, they don't have that ability anymore to recall those memories. So this is not going to work for them as well. Not anymore. What about letter C? Reorient the patient to the date and time every 4 hours. Every 4 hours. Remember about the decline in their cognitive ability? When you're going to reorient them, we're talking about severe. I'm not talking about the first and second stages. Severe AD. When you're going to present them to the reality orientation much more frequently, this can become confusing for them. It will become frustrating, especially with a severe form of the Alzheimer's. They will not be able to retain the information and they will become more agitated. So there's no actually use of repeating the date and time every 4 hours if they have the severe Alzheimer's disease. However, this can be useful during the first and second stages. But if we are talking about severe, it's not going to work. They don't have the sense of time because of the severe cognitive decline. There's no use. It will just make them more agitated. If you're going to repeatedly attempt to reorient them, will cause more agitation. We're talking about severe Alzheimer's disease. Will cause more agitation. Again, we can do this frequent orientation to the first, second stages, but not in this patient case. So the best answer here will be letter B, maintain a consistent daily routine for the care. All right? It will reduce their anxiety and it will also reduce their confusion and also their agitation. Make sure that they have a much more predictable environment and familiar activities. So the best answer here for the severe Alzheimer's disease is letter B. All right. Let's have number 5. A patient with Alzheimer's disease has a history of wandering and is being admitted to a long-term care facility. What action should the nurse take? A, frequently reorient the patient throughout the day. B, ask the family to bring familiar items. C, assign a room close to the nurse's station. D, question the patient about the reasons for wandering. Our case here is on a patient with AD, has a history of wandering, and is being admitted for long-term care facility. We're talking about long-term care facility admission, not acute care. History of wandering. What do you think would be safe for this patient? Are you going to do letter A, frequently reorient the patient throughout the day? Or is it B, ask the family member or family to bring familiar items? Or is it C, assign a room close to the nurse's station? Or D, question the patient about the reasons of wandering? What would be helpful? Let's have letter A first. Frequently reorient the patient throughout the day. Again, our patient that has the Alzheimer's disease have the short-term memory loss, which is going to, the frequent reorientation is going to be ineffective. It will just not work. It will not prevent wandering. Okay? What about letter B? Ask the family member to bring familiar items. What do you think about that? It can provide comfort to the patient, but it's not directly addressing the issue of wandering. It isn't. It's not going to prevent. Not a preventive measure against wandering. It's not. We are going to select a preventive nursing action. It's not going to help. What about letter C? Assign a room close to the nurse's station, which apparently, in my experience, yes. Ideal setting, you're going to place the patient close to the nurse's station in order to have a much closer observation. There will be more people that will be able to observe this patient if they try to sneak out. Yeah, the proximity of the patient's room at the nurse's station will give you a better or quicker response in case when the patient attempts to wander around. Okay, so you got to do this. You're going to assign a room closer to the nurse's station. All right, and with the experience I have, I just hated it when I get assigned to those rooms closer to the nurse's stations, because I now know that these patients are wanderers, and I hated that so much, even though I don't really hate the patient. But the assignment, if it's gonna be a weekly thing that you're gonna be assigned to the same kind of room, yeah, it will really suck you dry. Yeah, it can be overwhelming, especially if you're gonna be assigned to those rooms, close observation rooms. It can really exhaust you if you're going to be given the same type of patients every time. Yeah, it's exhausting. It's very challenging. I like to deal with these patients or take care of them, but when it's just repetitive, yeah, you need at least to deal with some other types of patients as well. Let's talk about letter D. Question the patient about the reasons for wandering. What do you think about that one? Will that help out? If you're going to ask the patient, why are you doing this? This is going to be unproductive, and it will just lead to the frustration because they don't have a clear understanding of their actions. No, they don't have. Patient will not understand. Their behavior. They don't have really an exact reason why they're doing it. So if you're just going to ask them why, it will not do any good. You just have to do your preventive measure. Basically, you got to place them closer to the nurse's station. So this test question is actually going to be about safe and effective care. Don't neglect this, because this is going to appear more often in the NCLEX. Safe and effective care. You need to be able to prioritize those nursing interventions, especially for those patients with AD. They are prone to wandering. So in this test question, make sure that you're selecting those that can prevent this patient from doing anything else. Let them stay in the close proximity, but not let them wander. Let's have number 6. A nurse is taking care of an elderly male diagnosed with Alzheimer's disease. The patient's daughter inquires about her own risk of developing the disease. How should the nurse respond? Is it A, being a woman increases your risk? B, genetic tests can definitely determine your risk? C, people with the apolipoprotein E2 gene have a higher risk? D, getting older and having a family history are significant risk factors. Hello, James. Welcome back. And for those who are new to the classroom, welcome, guys. We appreciate you for attending. I hope that you can hang tight with us. Make sure that you stay with us up until the end of our session. What is your answer for this item number 6? A nurse is taking care of an elderly male patient diagnosed with Alzheimer's disease. The patient's daughter inquires about her own risk of developing the disease. How should the nurse respond? Yeah, guys, you had the clue earlier, right? We talked about the risk factors. So advancing age is the topmost risk in the development of AD, which is letter D. Getting older and having a family history are significant risk factors. The genetic composition is going to be a secondary risk, all right, as we have talked about earlier. The genetic mutation, yeah, it's not the primary risk in the development of AD. What about letter A? Being a woman increases your risk? First time, welcome. Antoinette Rowe, welcome. You are welcome to stay with us as well in the succeeding reviews tomorrow. We are doing this every day, 9 p.m. Eastern time. So you are free to join with us. If you stated this one, being a woman increasing your risk, gender alone is not a risk factor for Alzheimer's disease. There is high prevalence of the occurrence of Alzheimer's disease because of their longer lifespan. They live a lot longer, and so they will be prone to have more of the AD, not because of the gender itself. That, I mean, it is the longer lifespan that can predispose them to suffer or develop the Alzheimer's disease. It's not specific biologically for them, okay? Now, let's talk about letter B. Genetic tests can definitely determine your risk. What did we talk about earlier regarding the apolipoprotein? Remember that there are no currently definitive diagnostic tests or genetic tests. No, none. It's not gonna predict, okay? It doesn't. The genetic mutation that we talked earlier is only going to be a helpful marker, especially for those who have the increased risk. That's totally different. They do not provide a definitive prediction of the disease onset. It will only be a marker of their increasing risk. It will not give them a good prediction of when the disease will exactly happen. So we are marking this as wrong as well. So we are going to select letter D. All right, for some reason, my vision is just kind of blurry today. I'm not quite sure what's going on. Number 7, the day shift nurse. Do you do one-on-one tutoring? At the current time, not yet. Not yet. I will probably do this in the future, but in the current, no, not yet. Question number 7. The day shift nurse at a long-term care facility learns that a patient with dementia has experienced sundowning late in the afternoon for the past 2 days. What action should the nurse take? Please pay attention to the scenario, guys. The day shift nurse at a long-term care facility learns that a patient with dementia has experienced sundowning late in the afternoon for the past 2 days. What action should the nurse take? Is it A, encourage the patient to take a nap in the late morning? Or is it B, keep the blinds open to allow daylight into the room? Or is it C, provide hourly reminders of the date and time? And D, move the patient to a quieter room in the afternoon? All right, James answered letter B. What about the rest of you? Adiola answered letter B. Okay. James, where are you working? Are you working in a long-term care facility right now? Or do you have experience with the Alzheimer's patient currently? Because this would be really helpful. Okay, let's take a look onto letter D. Move the patient to a quieter room in the afternoon. Quieter room? Conducive to sleep? Yeah, they can sleep when they're going to be placed in the quieter room. When we are going to, not really. So let me just explain here. If we were answering letter D, move the patient to a quieter room in the afternoon. Well, if you're going to do that, placing them into unfamiliar room can increase their agitation and confusion. Can increase agitation and confusion. It's not really going to be conducive for sleep since they're going to be placed in a newer environment. So they will find more comfort if they're going to be familiar with the current environment. So consistency is key here in our Alzheimer's patient. So with the patient that is already known to have sundowning in the late afternoon, you're actually aggravating the patient's condition. If you are doing letter D, aggravates sundowning. So never do this, especially for those patients that have the sundowning episodes. This can disrupt their routine and also increase their confusion. Agitation is a big deal. So do not put them in a less familiar environment. Crossing that out. What about letter E or letter C? Provide hourly reminders of the date and time. What do you think about the hourly reminders? Do you think this will be helpful? Remember about the patient with the sundowning. They are in the severe form of the dementia already. So if you are doing the frequent orientation, we are talking a patient with the sundowning. The dementia is already getting severe here. So if you're going to do a lot of frequent reorientation, this is not going to be effective. It will be effective in the earlier stages, stage 1 and 2, but not in this stage. This will not help out because they already have a significant decline in their cognitive ability. And the patient is basically manifesting those internal biological clock changes, okay? So it's the sundowning itself is due to the disorientation, okay? And again, this is because about the internal biological clock and also the environmental factors. So hourly reminders will not be effective here. Sundowning patient is not going to be able to understand about the time. So let's have letter A. Encourage the patient to take a nap in the late morning. Okay, I guess I got that right. Encourage the patient to take a nap in the late morning. What do you think about that? Late in the morning. If you're going to allow the patient to nap, especially on those irregular hours, then this can also disrupt the patient's natural sleep-wake cycle. It can lead to further disruption in their circadian rhythm and can also worsen their sundowning symptoms. So napping, encouraging them to sleep during the daytime will aggravate the sundowning. We need to encourage much more physical activity, stimulation during the daytime. This will lessen the sundowning episode. We don't have any more option but letter B. Keep the blinds open to allow daylight into the room, because with exposure to the natural light, this can help regulate the patient's circadian rhythms. They need to be exposed to the natural lighting, okay? So opening the blinds would really get them more stimulated. Also will support, again, the sleep-wake cycle. Answer is letter B. Let's talk about number 8. Woohoo! Again, guys, we are inviting you to enroll in our NCLEX course at www.stancoastnclexcoaching.com, and also check the link below in the description box to know more about us. And that's it. Number 8, an older adult with Alzheimer's disease is admitted to the hospital. The patient's spouse reports the patient often gets confused and loses their way while walking to the store. That evening, the nurse notices the patient pacing the hall and shouting. What should the nurse do? Is it A, inform the provider about the patient's worsening condition? B, prepare the spouse for the patient's imminent death from Alzheimer's? C, request a higher dose of medication to manage the increased symptoms? D, explain to the spouse that this behavior is typical as the disease progresses. So your patient that has Alzheimer's disease is now confused, loses their way while walking to the store. Previously, now. So these are the presenting manifestations. They lose their way while walking to the store. And during that evening, especially in the hospital, while the patient was already admitted, the patient is now pacing the hall and shouting. I'm seeing letter D's right now. Okay, that is the correct answer, guys. Woohoo, congrats. Letter D. You're going to explain to the wife or the spouse that this is an expected behavior when there is now a progressive Alzheimer's disease. Okay? Our patient spouse should be reassured that these symptoms are part of the natural progression. Okay? Because the pacing of the halls, the shouting, they are common behaviors, especially when they get agitated and confused. So again, we're talking about the severe form of the AD. Okay, so instead, what we're going to offer to the wife or the spouse is to give them education. We need to reassure them that we'll help them understand about the progression, why these things are happening. In order for them to have much more understanding, they will have decreased anxiety. The spouse themselves will be anxious whenever they will see their husband yelling and cursing maybe in the hallway. So just explain to the spouse that this is a common manifestation, especially when the disease is advancing. So they will be reassured that this is a common theme, nothing to really worry about, in order for them to have lesser anxiety as well, so they can cope better themselves with the sudden change in the patient's behavior. Now let's talk about letter A. Inform the provider about the patient's worsening condition. Do you think that this will address the scenario? Remember that we are talking about the patient's spouse reporting to the patient's spouse. Okay, so we're actually going to have to deal with the family member, the patient's spouse. We are going to promptly give the education to the family member or the spouse. If you're going to answer letter A, calling the medical provider or informing the medical provider, this is going to be expected. So there's not even a reason why we should be calling the medical provider this time. It does not require immediate provider notification. Does not require immediate notification to the provider. Yes, we can inform the medical provider when they're available, but immediately or informing the medical provider, it's not going to be, there's no enough reason for that, okay? The agitation, again, is caused by the wandering, the pacing, it's caused by the agitation and confusion. Now let's talk about letter B. Prepare the spouse for the patient's imminent death. That is so unhealthy. The progression of the Alzheimer's disease basically will vary. It's not indicating that the patient has imminent death. This is a chronic condition, and it has a variable course. The behavior that they were displaying here, which is the pacing, the wandering, is part of the disease process, but does not imply that there is imminent death. No, part of the process. So if you are going to select letter C as well, request a higher dose of medication to manage the increased symptoms. Yeah, we know of nurses are actually just wanting to control their patients with meds, and this is very inappropriate this time, okay? Request a higher dose of medication. We know that we can actually incorporate meds to manage their behavioral symptoms, but increasing the dose without first assessing the situation, and also considering alternative intervention is not recommended in this scenario. Okay, so we want to make sure that before we're actually request for a higher dose, we need to identify first what really is causing the problem or what aggravated, okay, before we request for more medications for this patient. And guys, the more medications that they are taking, especially with their with this type of age, the more that they're going to end up with adverse reaction. So be careful. In the elderly population, polypharmacy is a huge thing. They will suffer more of the adverse effects. Now let's talk about number 9. A nurse is caring for a patient with moderate dementia who becomes increasingly restless and agitated. What should the nurse do first? Is it A, remind the patient of their location and identity? B, give a prescribed dose of lorazepam, Ativan. C, investigate possible causes of the patient's discomfort. Or D, assign a staff to stay with the patient. So our scenario here is a patient with a moderate dementia becomes increasingly restless and agitated. We are being asked here what step you should do first. Okay, let's have the options. Letter A, remind the patient of their location and identity. Your patient has what? Moderate dementia. Increasingly restless and agitated. When you're choosing letter A, reminding the patient of their location and identity, it's unlikely that this will calm a patient down with moderate dementia. Okay, unlikely to help them relax or more comfortable. They will have much more of the disorientation and confusion, which may contribute to the agitation. So simply reminding them of their location is unlikely to manage this patient. It's not. What about letter B? Give a prescribed dose of lorazepam or Ativan. What do you think about this one? And I know nurses are very quick in medicating their patient as soon as they see their patient is agitated. Boom, going right away into the bedroom and grabbing that Ativan pill. Oh boy, we see a lot of patients in the unit that are actually drugged, or even sedate because of the abuse in the use of these lorazepam. So if you're using letter B as your answer, you really want to assess first what is causing their restlessness, their agitation. So our correct answer here is to investigate the possible cause of the patient's discomfort. Is it because they have some pain that they just don't know how to express themselves? Or maybe they cannot urinate effectively. Maybe they have a full bladder and they now have a urinary retention. Or maybe they have a urinary tract infection because of the urinary retention. Or they probably are constipated. They are not able to pass their stools because of the medication, the diet, poor activity, poor fluid intake. There are so many things that we can address here, guys. So we need to investigate further what the cause is, okay? If we're going to do letter B, this is not the first intervention that you should be doing without assessing the patient first. You need to assess first. Assess, investigate before grabbing the chill pill. I call that as a chill pill, the Ativan. Not a priority nursing action this time. I know that it can manage the anxiety, agitation, but should not be the initial response for this patient without first assessing the reason why they become agitated. If you're going to put, or if you're going to select letter D, assign a staff member to stay with the patient, in the current practice, putting a sitter or let's say a staff can be helpful. It can be necessary, but it should follow the assessment of the patient's needs. Okay, this is huge. This is important, guys. I'm not telling you that we're not supposed to assign a staff or a sitter. Okay, in California, placing a sitter is very common, especially for those patients that are very agitated, severely agitated. And yeah, I've used sitters way back in my bedside practice. I even encourage the family members to sit or stay with the patient if they're available, which is really going to be helpful, right? But again, this will not take priority in place of the assessment. We need to carefully assess what really is the cause of the agitation before we're going to end up putting just a sitter, because we are probably just adding more cost to the patient's admission. It will add cost. Putting a sitter can actually add more expenditure, right? If you're just going to pull somebody to sit, maybe a CNA that's been helping 30, 40 people in the nursing unit, if you're going to pull this person unnecessarily, it can also impact the overall care of the other patients in the nursing unit. Okay, so do not just put a sitter into the patient's room without further investigation. Okay, so indicating right now the answer is letter C. Number 10, when administering the mini-cog test to a patient suspected of having Alzheimer's disease, what should the nurse do? Is it A, assess the patient's awareness of time and date? B, review the patient's list of medications? C, ask the patient to draw a clock showing a specific time? D, test the patient's family to identify a common object like a pen. I already said this earlier, obviously. Mini cognitive testing. Guys, I said about the mini cognitive test earlier. I actually explained this, what the procedure is all about. So when you're doing this, what would be that? Is it A, assess the patient's awareness of time and date? My vision is really bad today. What's going on? Is that part of the cognitive test? No. Remember about the simple recall, the having the patient draw the second hand, the short or the short or the longer hand into the time, the numbers, and also, yeah, remember about that step that I have mentioned earlier? If you had answered the letter A, which is assessing the patient's awareness of the time and date, this is part of the general cognitive assessment, but not the mini cognitive test. We are talking about mini cognitive test. This is included. Letter A, please don't mistaken me for this, but letter A is included in the general cognitive assessment, right? But not the mini-cog. So we're talking about the MOCA. Okay. All right. So here, A, it's wrong. What about letter B? Review the patient's list of medications. What do you think about that one? Is it included in the mini-cog? No, it isn't. We're reviewing the medication is not part of the mini-cognitive test. However, though, we know that the review of the drugs that they're taking, prescriptions or maybe over-the-counter medications, it's part of the patient assessment during the admission, but it's not part of the mini cognitive testing. Let's have letter C. Ask the patient to draw a clock showing a specific time. This is what I said earlier, no others. If you answered letter D, test the patient's ability to identify a common object like a pen. No, not identification, but recalling. Remember about the simple recall? Recalling of what? Those three common items. You're going to have to ask them after you present those items. So you're going to tell the patient. So we're going to talk about these items: cup, mug, umbrella. So you're going to ask the patient to repeat those items that you just mentioned. Okay? So it's about recalling, not identification. So this is wrong. So the correct answer here is letter C. Let's have number 11. A nurse is deciding which patient should be placed in the room nearest to the nurse's station. Which patient should be given this room? Is it A, a patient with Alzheimer's disease who has issues with long-term memory? Or is it B, a patient? Yes, that's correct, Mary Flor. You're correct. Apple, table, pencil. Is it B, a patient with vascular dementia who is on medication for depression? Or is it C, a patient who became confused, restless, irritable with following surgery? Or D, a patient with dementia who has scored poorly on the mini mental state examination? What do you think about that? A nurse is deciding which patient should be placed in the room nearest to the nurse's station. Which patient should be given this room? Is it A, B, C, or D? Let's eliminate one by one. Letter A, a patient with vascular dementia, or is it vascular? Letter A, rather. Letter A, a patient with Alzheimer's disease who has issues with long-term memory. This is a patient that has the severe type, long-term memory loss. So we know that this is a chronic disorder, right? This is a chronic disorder. It is expected. There's no change in the patient's behavior. As stated in the option, long-term memory. So do you think that this will require higher observation this time? No, there's no enough information that the patient is agitated or rambunctious or combative. So we are not going to place them into the nurse's station doorway. Okay. What about letter B? A patient with vascular dementia who is on medication of depression. Vascular dementia. Well, the patient here is actually in a stable condition, and he will not require immediate risk or for any safety concerns as well. So they don't require a higher visibility. So we are going to consider placing patient in higher visibility. Frequent observations. This is the goal for this placement. Higher visibility, so anyone can check on this patient. Observation even from afar. So if the patient is letter B, again, they are going to be much more stable. There's not enough information about the patient's need to require this room. What about letter D? A patient with dementia who has scored poorly on the mini mental state exam, which is one of the cognitive testing. Well, the patient now has chronic dementia. And of course, when they have chronic dementia, they will score poorly. This is an expected finding. You will not expect a patient with a chronic dementia to score good in their MMSE. Of course, that is just not quite true. So there is no need for this patient again to be observed frequently. There's no enough reason for that. So we are left with letter C, a patient who became confused, restless, and irritable following surgery. Our patient will require much more observation, attention, assessment. There's so many things that you can do for this patient, guys. This is actually reflecting that the patient is having delirium. This is actually going to require a lot of attention, guys, especially after a surgical procedure. Following surgery, possibly because of the effects of the anesthesia, delirium can be a life-threatening occurrence to our patient. They will not be easily redirected. They are going to be very combative, restless, and this is going to require immediate assessment and close monitoring to prevent complication. When they are going to develop delirium, they are at a higher risk for falls. Yeah, they will cause injury into themselves. Maybe they can pull those IV tubings, Foley catheters, or whatever dressings that they might have. They will be pulling those out, and it can lead to adverse events. Pulling of IV access, possibly central line, catheters, dressings, that can really harm them, especially in a post-surgical phase. We need to keep those dressings intact. And so if they're touching all over the place, this will really complicate all things. Very close monitoring. It requires one-on-one monitoring. Yes, this patient will actually require a sitter this time. One-on-one sitter. Yeah. And once when I was actually a team leader, and the acuity of the nursing unit, the neuro floor, was so high. I was the team leader, but the number of patients that we had really required a lot of care by the nurses' aide, so we did not decide pulling them into sitting for this patient. Well, I ended up being the sitter because I can now closely observe the patient. So I ended up being the primary care nurse for this patient, a 1-to-1, okay? Especially with the post-op phase, hydration is really important, making sure that we're monitoring them for any signs of hemodynamic instability, oxygen saturation, and also if there are delirious, because maybe they're in a lot of pain, we need to address those. Assess carefully your patient in order to prevent these life-threatening complications. It's not fun, guys, working in the neuro unit. And on top of the strokes, the CVAs and other, it's wider in the challenges compared to the cardiovascular unit, because we have a mixture of cardio patients as well. Trust me, it's crazy. It's like a what do you call this? Every time I come into the floor, I would just say, "Welcome to paradise." Number 12. After receiving the shift report on a unit for patients with Alzheimer's disease and dementia, which patient should the nurse assess first? Again, after receiving the shift report on a unit for patients with Alzheimer's disease and dementia, which patient should the nurse assess first? Is it a patient who hasn't had a bowel movement in 5 days? B, a patient with a stage 2 pressure ulcer on the coccyx? C, a patient refusing to take their prescribed medications? And D, a patient who developed a new cough after eating breakfast? Again, the statement said, after receiving the shift report on a unit for patients with Alzheimer's disease and dementia, which patient should the nurse assess first? Is it the patient that had no BM for 5 days? B, a patient with stage 2 pressure ulcer on the coccyx? C, a patient refusing to take their medications, prescribed medication? Oftentimes they will refuse. Letter D, a patient who developed a new cough after eating breakfast. What do you think about this scenario, guys, or the options? If you selected letter D, that is the correct answer. Okay. New cough after eating breakfast. This is a sign of aspiration pneumonia. This is going to require immediate action, right? Letter D, aspiration pneumonia. We are talking here about airway clearance. Okay? Try to prioritize your patients, guys. Prioritize, prioritize. Airway clearance is compromised this time because of a possible ingestion or inhalation rather. Inhalation of food particles. A new cough is a new assessment that will require critical assessment and monitoring. We need to prevent the possible complications. So we need to do more investigation per patient, listen to the patient's breath sounds, lung sounds, look into the oxygen saturation as well. If there is a drop in their oxygen saturation, O2 sat, increase in the respiratory rate, the heart rate, and also possibly a slight increase in the diastolic blood pressure. Take note of these early signs that you should keep in mind. Okay? This can lead to sepsis. So oxygen saturation monitoring, the respiratory rate, heart rate, and also a slight increase in the diastolic blood pressure. These are early signs of a possible sepsis. So these are things that you need to keep in mind. You need to do a lot more monitoring in this patient. Okay? Once you have done your assessment, then you are going to call MD. Why you need to call? Because this is abnormal assessment. This is a new finding. You need to obtain more orders to confirm for aspiration pneumonia, probably chest x-ray or any other testing. You need to get things on board early as possible. Okay? Now let's talk about letter A, a patient who hasn't had a bowel movement for 5 days. Yes, you will encounter patients like this in the med-surg, especially for those taking those opiates, benzos. They will not be passing stools for this long time. It is a concern, guys. We know it is a concern, but the constipation needing attention does not pose an immediate threat compared to the patient having an airway issue. Okay, so we can put this patient as a secondary priority. Okay, important to address issue, but there's a higher priority, which is the patient in D. Letter B, a patient with stage 2 pressure ulcer on the coccyx. Is it life-threatening compared to the patient with airway issue? No, we can deal with the stage 2 ulcer after we had dealt with letter D. What about letter C? A patient refusing to take their prescribed medication. Yeah, this will be a difficult patient to deal with. We can address this after we had dealt with letter D. Medication refusal, guys. Let's talk about refusal. This is going to be a common theme as well in the med-surg, especially dealing with the elderly people. This is going to be a significant issue in the care continuity, but it again is not going to pose threat compared to the potential aspiration or the aspiration pneumonia that is going on in our patient. Okay, what you can do with this patient with a refusal of medication is it's not even specified if the patient is confused or alert oriented. It's not. So what you're going to do here, if they're refusing, just let them know that these are the benefits of taking the drug and the risk of not taking the medication. You have to educate them. If still they are resistant to taking the medication, you need to inform the medical provider and making sure that they're aware about their refusal, right? And document in the medical record in order to have that information available in case they will refuse the next set of medications. So maybe this patient would probably require more education, maybe have them sign the waiver refusing treatment, and this is significant as well that you should be doing as well. Let's talk about number 13. The spouse of a 70-year-old male patient in the early stages of Alzheimer's disease expresses feeling constantly worried and exhausted. Welcome back, virtuous lady. I haven't seen you for 2 days. Was it 2 days? Again, the spouse of a 70-year-old male patient in the early stages of Alzheimer's disease expresses feeling constantly worried and exhausted. What actions should the nurse take next? Select all that apply. Is it A, suggest considering a long-term care facility? Is it B, provide strategies for distracting or redirecting the patient? Or is it C, informing the spouse about adult daycare options for respite? D, recommend the spouse to consult with a physician. Recommend the spouse consult with a physician about anti-anxiety medication. E, inquire about the spouse's knowledge and considerations requiring dementia care options. This is a select all that apply, guys. You are free to select all the appropriate answers. What do you think are those answers? James answered B, C, E. What about the others? Well, waiting for your answers, guys. I'll start rationalizing. Let's have letter A. Suggest considering a long-term care facility. Okay. Remember that it's stated in our scenario, early stages of Alzheimer's. Expresses feeling constantly worried and exhausted. The spouse of a 70-year-old male patient with early stages of Alzheimer's disease expresses feeling constantly worried and exhausted. What action should the nurse take next? If you were going to suggest letter A, long-term care facility, this is too premature for this patient. Okay, early stage of Alzheimer's, very premature to suggest long-term care because the patient this time can still typically be cared for at home with appropriate support. There is alternate or there's an alternative what do you call this, care that we can provide to this patient. Home care. Yeah. Long-term care facility, too premature. There are so many other options that can be done to promote care for this patient in the home setting. Okay? All righty. Let's have can do home care. Maybe daily visits by the caregiver, or maybe a stay-in caregiver. That's an option. What about letter B? Provide strategies for distracting or redirecting the patient. Strategies to distract. Yes, these can actually help manage the patient's challenging behaviors, and this will also reduce the stress onto the spouse. So again, distraction, strategies, redirection are going to be helpful in de-escalating and also managing the patient's behaviors. All right, that's one of the answers. Answers. Let's have letter B. What about letter C? Inform the spouse about adult daycare options for respite. Yeah, this is also possible. They can provide the spouse with the necessary breaks from the caregiving. This is what we call as adult daycare programs, and this will structure those activities. They can supervise the patients with Alzheimer's disease, and it will give the caregivers, the spouse or the family members, it will give them some time to take care of themselves. Alone time, self-care. We know about the compassion fatigue, right? Yeah, it is very common among family members. So we need them to have this alternative in order for them to have some care for themselves. All right. And we also need to provide the patient's needs, making sure that somebody is able to provide for the patient's need. Letter C is also an answer. What about letter D? Recommend the spouse consult with a physician about anti-anxiety medication. Do we have an indication that the patient would require this right now? Maybe it is appropriate, but there are some other measures or supportive measures that we can try at first. Again, it might be appropriate, but again, start with other alternatives. This is not our first line intervention. Anti-anxiety meds, not first line option. We have other alternatives and approaches. What about letter E? Inquire about the spouse's knowledge and considerations regarding dementia care options. This is actually broad. Understanding about the spouse's current knowledge is very helpful in order for us that we can tailor the education and also the support that they need. And we need to do the assessment, guys. Make sure that we have enough information, that the spouse has understanding about the concerns, and also it will give them better options. Also, the care providers, right? It will give us better options in personalizing and customizing the education so that we can address those specific needs as well. So we have BCE rather. So letter D is not part of it. So BCE. I have to move closer to the screen because I can barely see today. Inquire about. All right. Now let's talk about number 14. But before we go do that again, we are inviting you to enroll to our NCLEX program. Kindly visit www.stancoastnclexcoaching.com and also click on the description box below to know more about our course offering. Now, what we are actually being asked here in this situation in question 13, these are, the question basically is geared towards identifying those interventions that will provide immediate and practical support to the caregiver, okay? Especially that the scenario stated about the spouse is worried and exhausted. This is not going to be healthy for the spouse as well. This is going to cause more stress. So we need to look for those interventions or options that will give them support, and also that will give them an ability to cope in order that they can manage with the huge responsibility. So the better that they are educated about the options or alternatives, the more that they'll be able to, hey, yeah, I think that's a good idea, right? I think we can start with home care this time. Or maybe I will enroll my husband into the adult daycare. These are all possibilities that will prevent the caregiver's fatigue. Let's talk about number 14. Which tests Can the nurse delegate to a licensed practical nurse or vocational nurse who is part of the care team for a patient with Alzheimer's disease? Select all that apply. Is it A, create a plan to manage challenging behaviors? B, administer the prescribed medication memantine, Namenda? Or C, eliminate safety hazards in the patient's environment? C, refer the patient and caregivers to community resources. E, assist the patient and caregivers in selecting memory enhancement techniques. And F is assess the impact of enteral feedings on the patient's nutritional status. Please refer to the options. I probably have misread those. Oops. So what are those options that will be appropriate for this patient? Or for this delegation, we are going to delegate the task to an LPN, LVN, especially in the care of our patient. Okay, be careful, guys. Be careful. All right, let's try to eliminate stuff. Letter A, create a plan to manage challenging behaviors. Well, if you're going to answer, or if you're going to select this, especially creating a plan, the creation of the plan is under the scope of RN. The LVNs, the LPNs should not be doing the care planning. Okay, it is the responsibility of the registered nurse to create the care plan, especially with challenging behaviors. The LPN, the LVN don't have this capability, okay? Especially with the challenging behaviors with Alzheimer's disease. This will require comprehensive assessment. Remember that when you're creating a plan, it will require first assessment. And assessment, especially baseline assessment, this will also require an RN. RN scope of practice. And especially with strategies as well. Planning, right? That's another. Strategies. If we are talking about strategies, implementation, those are actually going to fall under the scope of the RN. Okay? So if you answered about selecting memory enhancement techniques, this is part of the RN scope of practice. So this is wrong. Same thing with letter A. Strategy, selecting memory enhancement techniques, that's part of the plan. That's not under the scope of the LVN, LPN. All right? Now what else? Let's have letter B. Administer the prescribed medication, memantine or the Namenda. Are they able to do that? Of course. They are qualified to administer medications. They can, under the supervision of the RN or the medical provider, as it falls under their scope of practice. No issue with that. They can do letter B. What about letter C? Eliminate safety hazards in the patient's environment. Of course, they can do this. Identification of those safety hazards. This is very important. Even the nurse's aide can do the identification or elimination of the safety hazards. They can. That's under the LVN scope of practice includes this one. They can ensure a safe environment for the patient. Okay? What about letter D? Refer the patient and caregivers to community resources. Referral? No. Referrals will require a level of an RN expertise. No. Only RNs. They cannot do referral, guys. This is supposedly the RN doing this one because it will require a much more comprehensive assessment as well. Planning, same thing. Coordination of care. Again, referral will involve assessment that is more comprehensive. Let me try to fit this one. Comprehensive assessment. It will also involve planning and also the coordination. These are huge chunks of interventions. So only the RN can do the referral. If you are answering letter F, assess the impact of enteral feedings on the patient's nutritional status. Again, this is assessment. Impact of enteral feedings on the patient's nutritional status. This constitutes initial assessment. Okay? All right? This is going to be more appropriate for an RN to do. Okay? Again, assessing the impact of enteral feedings, especially initial. This is going to be an RN scope only. They can do assessment as well. I'm not saying that they cannot. They can. But especially with this statement, assess the impact of enteral feedings, this actually pertains in the context of assessing the impact of the enteral feedings in nutritional status. The context is actually about baseline assessment or investigation. So it should require an RN to do that. Okay? So regarding number 14, our goal for this test question is to refamiliarize with the scope and practice of the RNs, LVNs, and so we can delegate properly those tasks, okay? The LVNs can administer medications. They can also ensure safety of our patient, but if it's going to involve a much more comprehensive assessment, planning, coordination, creating care plans, referral, assessment of complex scenarios, no, those are going to require an RN to do those things. Okay? And it's very complex. When I was back in the bedside, I've dealt with supervising LPNs, LVNs while orienting a brand new nurse. Isn't that amazing? No, it's not really amazing. It's very complex, dealing with a lot of patients and while orienting a newbie nurse. I've been a preceptor for that long, for 14 years, and it's quite challenging to deal with supervising other staff and also orienting a newbie into the organization. You really need to peel your eyes wide to see those risks that might be occurring in your shift. It's very tough, guys. Number 15. A nurse is educating the spouse of a patient who is starting a cholinesterase inhibitor for early Alzheimer's disease. Which statement, are we reading the same? Which statement by the nurse, or by the spouse rather, I'm misreading stuff. Which statement by the spouse indicates a need for further education? Is it A, gastrointestinal issues are a common side effect of this medication? B, people on this medication should avoid taking antihistamines? C, this drug helps neurons that are still healthy to function better? D, the drug significantly slows the disease progression. We are talking about a cholinesterase inhibitor indicated for early Alzheimer's disease. Remember about the anticholinesterase? They are also used in the myasthenia gravis. But here we are also using the anticholinesterase, but with a specific generic name and brand. Not really brand, but generic rather. Careful, guys. Which statement by the spouse indicates need for further Education. Patient is started on cholinesterase inhibitor. What do you think? All right, let's start to eliminate. I'm seeing letter B, C, D. Okay, what about the others, guys? I want to see your answers as well. All right, let's answer the correct answer, option rather, first. The correct answer for this is letter C. We are going to look for that incorrect statement. This is our task. Incorrect statement. This drug helps neurons that are still healthy to function better. So what do you think would be the correct answer instead? Dun, 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 dun. Let's have letter D. This drug significantly slows the disease progression. What's happened to my pen? Why it's not moving? Okay. Significantly slows the disease progression. This statement is incorrect. This is what we are looking for. Okay. The medication that we are giving to them, especially the cholinesterase inhibitors, can provide improvements. Okay. It will be indicated to diminish the manifestations, but they do not slow the disease progression. No, this is wrong. It doesn't have that effect. Does not slow the progression of the AD. Okay. This is not similar to the multiple sclerosis. Remember about the medications that we're giving in a patient with a multiple sclerosis? They're going to slow down the progression of the disease. But here, the anticholinesterase will not have that property. It does not do any slowing down of the progression. It will only diminish the manifestations. Okay, it will treat the signs and symptoms. Okay, it can temporarily enhance their cognitive function, but will not alter the underlying progression of the disease process. Okay, so that is the correct answer. Okay, letter D. Answer is letter D. What about letter A? Gastrointestinal issues are a common side effect of this medication. Yes, that is a true statement. And so we are not, we are eliminating this one because this is a true statement. The patient will have nausea, vomiting, and diarrhea. So these are common side effects. N, V, and D. True statement. Okay, we are eliminating letter A. What about letter B? People on this medication should avoid taking antihistamines. Is it correct? Yeah. The antihistamines can actually interfere with the metabolism of the cholinesterase inhibitors, especially those first line or first generation antihistamines. They have anticholinergic effects. Remember, guys? Like Benadryl, antihistamines, like the first generation, diphenhydramine. they have anticholinergic effect. And this will cause drug interaction with the medication that they are taking, anticholinergic. When we're talking about this patient taking the anticholinesterase, or they're taking the cholinesterase inhibitors or anticholinesterase, they are going to use that drug in order to target that enzymes that cause the breakdown of the acetylcholine, right? And this is going to interact with the anticholinergic drug. So this is a correct statement. We are eliminating this one because this is a true statement. We are doing that. What about letter C? This drug helps neurons that are still healthy to function better. Yeah, like I've said, it will decrease the manifestations. It will allow those remaining functional neurons to work better. That is also a true statement. It will increase the levels of the acetylcholine in the brain, which will enhance the patient's communication between the neurons. Okay? The anticholinesterase will increase the levels of acetylcholine in the brain. So, this is also a true statement. All right. Our answer is D. Now, we're talking about the anticholinesterase. Let's talk about this. And we have already mentioned this in our myasthenia gravis, but this is totally, this is indicated for a different, quite similar. It's also useful in this patient with the Alzheimer's disease. So let's talk about the anticholinesterase inhibitors. These are the first FDA approved drugs for the AD. First FDA approved for the treatment of the AD. And so the reason again for this medication that they're effective, it's because they are going to prevent the breakdown of the acetylcholine in the brain, which is going to help improve the communication of the neurons between the neurons or the cells that are not yet damaged. So that is the reason why anticholinesterase are helpful. And they can also improve the patient's cognition, the behavior. It can also help in the baseline function of our patient, whatever is remaining in our patient, especially for those mild to moderate AD. Okay, so this is indicated for mild to moderate AD. Okay, they will not cure the disease or stop the progression. They will only delay the decline, the manifestation for a few months, but our patient is mostly controlled here in their manifestations. That's the main reason. Okay, so let's talk about the common drugs that you will encounter in the clinical setting. So what are these? So the donepezil or the Aricept, this is going to be indicated in the mild to severe AD actually. So the donepezil, are you familiar with this drug? Probably, yeah. So this is indicated for mild to severe type of AD. And we also have the rivastigmine or the Exelon. This is going to be indicated for a mild to moderate AD. And then we also have the galantamine or the razidine. This is also indicated, but for mild to moderate type of Alzheimer's disease. Now, talking about the Aricept this time, this is going to be given as every 8-hour tablet. It is a PO medication or oral medication. And the dose here will be ranging. It can vary as well, depending on the patient's severity of the disease. The rivastigmine or Exelon, this can be administered as a PO or a transdermal patch. Exelon, have you seen this in the clinical care? Rivastigmine, it can be in a form of a transdermal patch. Transdermal patch. Whoops. Okay, transdermal patch. So with this medication, I forgot to mention about the Aricept. This is excreted through the urine. The same thing with the Exelon. This is also excreted via urine. And also the bile, the GI tract. Galantamine, which is the razidine. This is also given as a extended release per oral medication. Extended release oral drug, ER. Okay, so you need to instruct the patient to take the medication whole. Do not crush the drug if it's extended release or sustained release. The patient should be taking them whole, not even allow them to melt the drug in their mouth. Ooh, that's going to be bitter. But do not crush, do not melt the medication if they are extended release or sustained release. Now, what are the adverse effects of the anticholinesterase? There are side effects and adverse effects. They will have, they're going to have some kind of they will have cholinergic effects. Remember about the cholinergic effect of the anticholinesterase in myasthenia gravis? All right, I want you to use the same concept here. So, since these medication elevates the acetylcholine, oh, here we go again. Acetylcholine. What do you think will happen? What will happen into the cholinergic effect? Well, of course, the patient will have cholinergic effects. And I want you to recall those cholinergic effects. You've seen them all? Good for you, James. So, what are those? If we are talking about gastrointestinal side effects or adverse effect, they're going to end up with the nausea, the vomiting, and the dyspepsia, which is the heartburn. Dyspepsia. There's also going to be diarrhea. So NVD, okay? NVD. You have some of these. NVD, nausea, vomiting, dyspepsia. They will also have dizziness. Don't forget the D's. Dizziness, which is on the cardiovascular, right? Or neuro. Also, the patient will have headache. This is a common adverse effect in the anticholinesterase. Now, what do you think would be the others, especially for the lungs? The adverse effect for the cholinergic drugs or the anticholinesterase, this can lead to bronchospasm. Bronchospasm. So if you have a patient that has trouble like asthma, well, they're not going to really respond to this medication safely. Yeah. So you got to be cautious in giving this medication for those who have medical history, such as asthma, contraindicated, okay, in asthma. Please take note, guys. It is a cholinergic drug, not an anticholinergic. So what else are you going to do here? We're also going to check on their cardiovascular effects. Aside from the dizziness, which I actually consider as a cardiovascular effect, or neuro, it can be both. What do you think? Even though they're not common cardiovascular effects, our patient can have symptomatic bradycardia. That's part of that cholinergic effect. Symptomatic bradycardia. So for those patients that may have a history of AV block, Atrioventricular blocks, yeah, not good for them. This can cause fainting, syncopal episodes, they will end up falling. And for those patients that may have history of pacemaker placement. So you got to screen your patients here before initiating the anti-cholinesterase medication. All right? You need to really weigh in the risk and the benefits. Make sure that you're careful, checking your baseline assessment. All right, enough with that. But don't forget about the cholinergic effects, the GI, NVDD, the headache, the dizziness. For the lungs, it can cause bronchospasm. For the cardio, it can cause symptomatic bradycardia. This will lead to those falls, injuries. Yeah, we don't want that. All right, let me clear this out. Let's talk about the next drug class, which is on the NMDA. Okay, this is the N-methyl D-aspartate. Let's just call it NMDA. All right, NMDA receptor antagonist. What is this? Well, this is a drug or classification of drugs that will be intended for patients who have moderate to severe type of AD. Okay, and what is the reason why this patient, why is this medication helpful? Why? Well, the NMDA can regulate the effects of glutamate, right? Regulates the effects of glutamate. Ooh, it's been 3 hours already. I gotta hurry up. So the patient here will have slowing down of their cognitive decline, especially with this kind of medication. Again, it is going to regulate the effects of the glutamate. Now, let's talk about the glutamate, really. What is really the function of the glutamate? Well, in the healthy individual, let's talk about healthy person. The NMDA receptors, okay? NMDA receptors in the neurons, they're going to regulate the calcium flow. Okay, so the role of the NMDA receptors is to regulate calcium flow. Okay, and normally the magnesium will block the receptor channel. So let's say, for example, this is our cell, the brain cells. Let me just simplify it. And so this is the receptor right here. In the normally functioning body, the magnesium will block the receptor channel. Okay, that's the magnesium right there. So it will prevent the entry of the calcium ions into the cell or the neuron. Now let's talk about the glutamate. What is the role of the glutamate in the neurotransmission? The glutamate will actually bind to the receptor. So the glutamate will also compete with the receptor. It will compete with the magnesium. Supposedly the magnesium is a protective electrolyte that will bind to the receptor in order to regulate the influx of the calcium ions, right? So it's like a guard. However, when there is increasing glutamate, which is another neurotransmitter, it will also bind to the receptor. So instead, what's going to happen here? It will displace the magnesium. No more guard. So once there is displacement of the magnesium, the calcium ions are now permitted freely to get into the cell. Okay? So the calcium ions can now freely enter into the brain cells. And this is going to impair the patient's overall neurofunction. It can now impair the memory, okay? The learning, if there is no control of the calcium influx into the neuron. And so when we are giving them the NMDA receptor antagonist, this is going to regulate the release of the glutamate. This is what we are controlling, okay? In order that the receptors are not overly activated. Because like I've said, if there is the Alzheimer's disease, the glutamate is actually known to be increased, which will allow lots of the calcium ions. So we are going to control the glutamate in order to decrease the entrance of the calcium ions into the cells by keeping the gateway regulated. Okay, so that's the reason why the NMDA medication is going to be effective. Now, the memantine will block the channel. It will replace the action of the magnesium. It will block the channel. And so the calcium ions will no longer be able to excessively enter into the cell. Okay, so that is the mechanism there. So I hope that you understand that component. Now let's talk about the example here, especially the memantine or the Namenda. What is the common dose? Do you know about the dose of the Namenda? It usually is going to be given in every 3 to 4 hours, 60 to 80 hours as well. I mean, the medication itself is going to be extended release, XR. So this is a medication that can be excreted in the urine as well. And it is known to be much more tolerated than the cholinesterase inhibitor. So this is the highlight, much more tolerated than anti-cholinesterase. Remember about the side effects, the adverse effect, the cholinergic effects? Yes. The reason why patients will like this drug much even more, it's because of the less cholinergic effect. It doesn't do that. All right. So even though it is more advantageous than the anti-cholinesterase, this medication can also have some side effects, dizziness and headache. So it's not really 100% side effect free. It still has side effects. So dizziness and also the headache. Okay? And again, guys, this medication is intended for moderate to severe Alzheimer's disease. It's not going to be indicated for the mild Alzheimer's disease, and it will not alter the underlying disease process. But again, it will give better or modest benefits. It will control the manifestations. Okie dokie, I hope that you're learning about the pharmacologic aspect of the the Alzheimer's disease. Let's move on with number 16. The spouse of a patient with Alzheimer's disease is learning about the rivastigmine transdermal patch. Which comment by the spouse indicates a misunderstanding? Is it A, that transdermal patch delivers the medications at a steady, lower dose? B, the patch has fewer side effects compared to oral medications? C, let me move around here. What page is this? 1085. 1085. Let me fix that real quick. 1085. Okay. Okay. Got that fixed. So those are the choices. A, the transdermal patch delivers the medication at a steady lower dose. B, the patch has fewer side effects compared to oral meds. And C, we only need to change the patch every 2 weeks. And D, we need to take off the old patch before putting a new one. Misunderstanding. We are looking for that statement that reflects misunderstanding of the teaching. All right, let's try to eliminate options. Letter A, that transdermal patch delivers the medication at a steady, lower dose. Do you think that is correct? No, it's the lower dose that's actually making this statement incorrect. No, not lower dose. There is going to be a steady, consistent release of the medication. So when you are going to apply this transdermal patch, the Exelon, are we talking about Exelon? Yeah, rivastigmine transdermal patch. This can give the patient the medication steadily throughout the 24-hour period. So it will deliver constant drug level. It doesn't mean that they're doing the patch or using the patch that they are getting slow, steady, or lower dose. That's not true. Even with the skin patches, actually, they're effective. They can give much better delivery of the medication into the bloodstream. In pharmacology, those are actually powerful medication, guys. Don't underestimate the patches. They are powerful routes of the administration. It is an effective route of administration. And so we are eliminating letter A. Let's have letter B. The patch has fewer side effects compared to the oral medication. Is that correct? The patch has fewer side effects compared to the oral medication. Do you think that this is going to be lesser? Yes, this is the correct answer. Why? With the application of a transdermal patch to the skin, the gastrointestinal side effects will be diminished. There is no longer GI side effects or adverse effects. Okay? Minimizes GI side effects. So if the patient has the oral route of the medication, then they are prone to getting the side effects, the NVD, right? Remember about the nausea, vomiting, dizziness, dyspepsia? Yeah, those are the manifestations in the oral medication. But it will not be common in the transdermal patch. So this is the correct, this is a correct statement rather. Correct statement. So I think I mistagged the number 1. So wait a minute here. Let me erase this one. The transdermal patch delivers the medication in a steady lower dose. Okay, I made a mistake there. Let's talk about letter C. It's time for lunch. We only need to change the patch every 2 weeks. Is it true? We only need to change the patch every 2 weeks. Okay, hang tight there. I haven't made my decision yet in A. Letter C. We only need to change the patch every 2 weeks. Is that true? Yeah, no. This is incorrect. The patch should be changed daily. All right. Should be changed daily. So this is also a, hang on a sec. I think I must have labeled my question wrong as well. Oh boy. Correct. All right. So lower dose. Actually, I made a mistake here in explanation here. Lower dose, but this is a wrong statement right here. This is what made me confused, the lower dose. It's not really lower dose. I actually added an information here that it's not accurate. Supposedly, this is just a steady dose, not lower dose. Okay, steady dose. So I made an error there. So I apologize, guys. I got so confused, like noticing into letter A. So let me correct this one really quick to clarify things. I made a mistake in adding the lower dose word. So let me change that one. Whoops. Steady dose. Okay. The lower dose was significant. So here we go. If you had answered already, if you answered it wrong, please retrieve your answers. I updated the option. Okay. So the question stated, which comment by the spouse indicates a misunderstanding? So if you chose letter A, the transdermal patch delivers the medication at a steady dose, yeah, that is a correct statement. So we will not be selecting this one. This is a correct statement. Okay. What about letter B? The patch has fewer side effects compared to the oral medications. This is also a correct statement. So we are going to remove that. What about letter C? We only need to change the patch every 2 weeks. This is the incorrect statement that we're looking for. So this is the correct answer. All right. Letter C. Letter D. We need to take off the old patch before putting a new one, which is a good practice, right? Before you are going to apply the new patch, make sure that you had removed the older one to prevent undue elevation of the drug dose, or let's say to prevent toxicity to the medication. Okay, we want to make sure that you will be inspecting the patient's skin. Make sure that you had removed that patch before applying the new one. That was a close call. So our correct answer here is letter C. It does not reflect understanding about the treatment. Okay, this is the changing of a patch. Okay, all right. Supposedly the A, the what made it wrong earlier, it's because of the word low dose. No, that's not quite true. It will deliver steady dose to the body. All right, let's tackle number 17. What time is it? 3:16. All right, I think I can do some more, or maybe this is the last one. A nursing student is learning about the memantine for Alzheimer's disease. Which student statement? Yes, very challenging, especially neuro type of questions. Man, I find them more difficult compared to the cardio stuff. But it depends. Maybe you have, if you are much more knowledgeable in neuro, then that's to your advantage, right? A nursing student is learning about memantine for Alzheimer's disease. Which student statement shows accurate understanding? Is it A, memantine is used for patients with mild to moderate Alzheimer's disease? B, memantine regulates the effects of glutamate, altering calcium flow into the neurons? C, memantine prevents calcium from exiting neurons, thus improving function? D, memantine combined with donepezil stops the progression of Alzheimer's disease. So use the concept that you learned in the mechanism of the medication, especially with the memantine. So please apply that. A nursing student is learning about memantine for Alzheimer's disease. Which student statement shows accurate understanding? Is it A, memantine is used for patients with mild to moderate Alzheimer's disease? Or is it B, memantine regulates the effects of glutamate, altering calcium flow into the neurons? Remember about the role of the NMDA receptor antagonist? Or is it memantine prevents calcium from exiting neurons, thus improving function? Or is it D, memantine combined with donepezil stops the progression of Alzheimer's disease? Remember, that's nothing is going to cure, right? Nothing will ever slow down the progress. So you're going to eliminate letter D already. Okay? Stops the progression? Nope. No such thing. No meds can do this. All right? There's only a control of the manifestations, the symptoms. Okay? What about letter A? Memantine is used for patients with mild to moderate Alzheimer's disease. Remember what I said about memantine, the NMDA? They are going to be indicated to the moderate to severe. Moderate to severe AD. So this is wrong right here. With the mild, this makes the statement wrong. The NMDA is only indicated for moderate to severe AD. So this is also wrong. Let's have letter C. Memantine prevents calcium from exiting. Did I say exit? No. Remember about the cell, the neuron. That's really not a neuron. It's just a circle. Remember about that receptor. And the calcium ions are actually waiting outside. Remember in the normal physiology, the magnesium are supposed to be the guards, right? It will block the receptor in order that the calcium will not be able to get into the cell. However, when we are giving the NMDA, since there is that glutamate. Remember about the glutamate. This is one of the neurotransmitters, actually. And so we are going to modulate the glutamate. We will give the drug, the NMDA will take into the role of the magnesium. It will block the channel, the receptors, and so that the calcium ions will no longer be able to freely get into the neuron. They can still, but not excessively. All right, which is basically going to improve the overall memory of our patient. All right, so letter C is wrong because it said exiting the neurons. It's not about the exit of the calcium. It is blocking the entry of the calcium. All right, so we are marking this wrong as well, letter C. So we have letter B, memantine regulates the effect of glutamate, altering calcium flow into the neurons. All right, guys, how are you? Are you understanding the mechanics about the NMDA? The drug action? Were you able to get the explanation? Because if not, I will do it again. Just kidding. Did you understand, guys, the mechanism of the memantine? Hello, I want to know if you understood. All right. So, I think I have one more. Let's do this. A nurse is monitoring an older adult with Alzheimer's disease who is on a cholinesterase inhibitor. Which side effects are most concerning? Is it confusion, memory loss, B, dizziness and headache, C, nausea and vomiting and diarrhea, or is it D, slow heart rate and fainting? We are talking about the cholinesterase inhibitor or the anticholinesterase. Which side effects are most concerning? Okay, good, thank you. What do you think about the cholinesterase inhibitor side effects that are most concerning? Is it the confusion or memory loss? Is it dizziness, headache? Is it the nausea, vomiting, or is it the slow heart rate and fainting? Remember what I said earlier about the cardiovascular side effect, about the neuro, about, not really. Oh boy. What do you think? Even with the diagram, I will do it for you, AJ, so you can understand. So I don't know what else I can do for you if you're not understanding the diagram. But let's answer this first. Remember about the most concerning, guys, is on the symptomatic bradycardia. Yeah, this is the correct answer. Slow heart rate and fainting. This is a side effect that is not really common, but it can be very concerning if it occurs. It can lead to the syncopal episodes and also injury to our patient. The nausea, vomiting, diarrhea, these are not really concerning. These are expected side effects, especially in the oral anti-cholinesterase, right? Oral anti-cholinesterase. All right. Anti-cholinesterase. Dizziness and headache. I know that this is one of the side effects, right? Yeah. But are they as concerning compared to the bradycardia? No. Confusion and memory loss. Well, the confusion and memory loss is already pre-existent in our patient. These are not specific side effects of the medication. So we are actually working on the adverse effect, rather. Adverse effect. Adverse effect. Okay? Headache, that's also an adverse effect. All right. So symptomatic bradycardia can lead to the false, more of the bradycardia, right? The conduction system, the arrhythmia. This is going to be most concerning to the patient. So, AJ, the NMDA, let me do this one more time, and I hope that you will get this. The NMDA medication, receptor antagonist. For the last time, the NMDA receptor antagonist will work as a blocker in the channel. This will be the gatekeeper. The medication that we are giving to the patient in Alzheimer's disease, the NMDA receptor antagonist or the blocker will keep the gate closed. For which neurotransmitter? The calcium. All right, it will not just allow the entry of the calcium ions into the cell. And remember that the glutamate, which is another neurotransmitter, this can also bind to the receptor. Remember this. The glutamate is another neurotransmitter that can also compete with the gate. So once there is a glutamate, this can allow the influx of calcium ions into the cell. But since we are going to give them the NMDA, this will now block the gateway. It will no longer prevent the glutamate from binding into the receptor. So it will prevent binding of the glutamate into glutamate in the NMDA receptor. So there's no more binding. So what do you think? This gateway will be exclusive, no longer going to allow the rapid influx of the calcium ions into the cell because there's no more glutamate working on it. So it's going to keep the calcium ions out of the neurons. It will now cause the patient to have much more improvement in their manifestation. Okay? That is the role of the NMDA. So I hope that you are understanding this time. So guys, I hope that you're also learning in today's lecture. And I will see you again tomorrow. We will still be talking about neuro stuff. For those inquiring about the pricing, please go ahead and click on the link below, or maybe into the Stancoast NCLEXcoaching.com website. Please click into that, or you can message us as well. I don't have direct information on everything, and so kindly message the team as well. All right. So thank you for your time and your participation today, and I'll see you again tomorrow at 9 p.m. Eastern Standard Time. I'll see you again. You take care, guys. Bye-bye.